Okay, excellent. Sorry, everyone, for the delay. We just had a slight broadcasting issue, but we are all good to go. So I declare open this hearing of the Senate Select Committee on COVID-19. I acknowledge the Ngunnawal and Ngambri peoples as the traditional owners of the Canberra area and pay respects to elders past and present of all Australia's Indigenous peoples. Today's public hearing provides an opportunity for the committee to examine impacts of the COVID-19 Omicron variant and the Australian government's response to this in areas which the Commonwealth hold responsibility. However, senators may use this opportunity to ask questions about other matters under the committee's terms of reference. Witnesses have been provided with information on procedural rules governing the public hearings, and these are available from the Secretariat. If a witness objects to answering a question, the witness should explain the basis for the objection in sufficient detail to allow the committee to determine whether to accept the objection. The committee will then decide whether to insist on an answer. Witnesses may request that answers be given confidentially. I remind those on video conference to mute their microphone when they are not speaking, and that's also for people on teleconference, and please ensure mobile phones are switched off or turned to silent. I now thank representatives from the Department of Prime Minister and Cabinet for attending today, and I appreciate your engagement in a number of dates which we had scheduled for this hearing, and my apologies for any disruption that they may have caused you. Would anyone like to make a short opening statement, or are you happy to proceed to questions?
Chair, if it's okay, I just wanted to introduce the staff members that I have available to assist in the response today.
Sure.
I'm Alison Frame, the Deputy Secretary for Social Policy Group in Prime Minister and Cabinet, and lead the coordination of the COVID response across Prime Minister and Cabinet, the department itself. I have Kristen Tilley with me, who is the First Assistant Secretary and the Head of the Office of Supply Chain Resilience in PM&C, and Mr John Neal, who is the Assistant Secretary of the COVID-19 Health Priorities Branch. Thank you.
Thank you very much.
Oh, and also online, further, there is Genevieve Quilty. Ms Genevieve Quilty is the First Assistant Secretary for Social Policy Group.
Thank you very much, Ms Frame. And can I just check who we've got on teleconference? We have Senator Patrick and we have Senator Rennick.
Correct.
Is that right?
Yes, that's correct, Chair.
Do I have Senator Watt? Okay, we're still waiting for Senator Watt. Okay, if colleagues can use the WhatsApp group to indicate whether they have questions. Senator Patrick, I know you do, for PM&C. Can I just start with a few questions just as background for the committee? But the national plan that was agreed at National Cabinet, I think in early August, sort of outlined the steps that and the benchmarks that would need to be taken as Australia opened up. What is the process for briefing the Prime Minister around that, between August and December last year? Is that a role that PM&C does, or is it a role that the Health Department does?
I think the answer to that question, Senator, is both. So it certainly features in discussions at National Cabinet, where there are quite specific conversations about elements of the national plan. And Health provides specific advice on vaccination rates and other metrics that are directly referenced in the national plan. But there, as I said, it is a discussion point at National Cabinet with regard to specific elements of the national plan. It has, as you would be aware, all states have moved beyond that 80% double dose vaccination rate, the last of which was in December, I think was the time frame for that. So at this stage, there's probably less active discussion of the national plan, given the Omicron wave at the moment that everyone is directly responding to, and the fact that there's that consistency in the national plan around Phase C and jurisdictions being in that specific phase of the response.
Okay, so how do briefings occur? Is it PM&C's role to brief the Prime Minister directly about sort of the changing landscape with COVID, particularly in November and December last year? Is that your job to brief the Prime Minister about that?
Certainly, the Department of Prime Minister and Cabinet provide updates and briefings on aspects of the COVID response. a lot of the health-specific aspects of the COVID response would be briefed directly from the Secretary of the Department of Health, the Minister and the Chief Medical Officer, Senator.
And was the Prime Minister provided with updates to modelling, particularly in November and December last year, about Omicron in particular, and how that might impact the national plan?
There was modelling undertaken by the Doherty Institute, Senators you're referring to, in late December, mid to late December, I think. That was modelling that was commissioned by the Department of Health and was the subject of discussion at the AHPPC. And the questions on the specifics of that modelling, it's different to the previous Doherty modelling in that it was commissioned from Health rather than the earlier Doherty modelling was commissioned from the Department of Prime Minister and Cabinet to serve the COVID Risk and Response Task Force that Secretary Gaetjens was leading with all First Secretaries. So that modelling on Omicron, which was mid to late December, I think, was the date, was led by the Department of Health. So they would be best placed to answer questions about that modelling.
But the Prime Minister would have been provided that through briefings from PM&C as well, presumably in the lead up to attending National Cabinet. PM&C would have a role there?
More specifically from Health there, Senator.
Okay, so does he get briefed directly from Health? He has separate meetings with Health that do not include PM&C, is that correct?
Typically, Senator, it would be briefings direct from Health where Prime Minister and Cabinet would be present. But the Department of Health and the relevant officials, the CMO, the Secretary, the Minister, will lead on aspects and lead on that direct briefing for work that they have led themselves, and Prime Minister and Cabinet are typically present. I can't think of any or many when we're not, but Health would lead where it is work that is health specific and has been led by them. Okay.
So, Ms Frame, you seem to be quite aware of what's happening in National Cabinet. Do you attend National Cabinet or are you briefed afterwards?
I attend National Cabinet, Senator.
Okay.
As a note taker.
You're a note taker? Okay, so how many people from PM&C attend National Cabinet?
The Secretary of the Department. I attend as the second note taker. There is a further note taker from the Department of Prime Minister and Cabinet who attend.
Okay. So can you tell me when... in that role, like when did you become aware that Omicron presented significant challenges to the national plan as was envisaged in August?
So, Senator, as you'd be aware, the dates for where Omicron became known and of concern, of some concern, there was so much that was unknown, but the increasing concern around Omicron was the last week in November. It was not in Australia at that point, as I recall, and there was a concern about border resetting and what might be needed at the international border in order to take more time to seek further information about Omicron and its severity, its transmissibility, vaccine escape, so many aspects that were not yet known. So it was very late November, early December, when we were becoming increasingly aware. This was all over a matter of days. And a decision was taken, as you know, to defer the expansion of the border reopening for 2 weeks while more information was sought on Omicron and those aspects that I just listed.
Okay, so on the 29th of November, the government announced the pause to the international borders opening for a fortnight. So at that point, it seems the government, what was their state of knowledge at that point? Enough to be worried to put a pause on the borders, so the information they would have been provided, presumably by Health, but with you guys present, was that some action needed to be taken at the end of November?
I would say enough to be worried about what was not known, Senator. The concern was about what was not known. That was the preeminent concern, that there was a new variant, there was not information available, and the CMO will obviously be able to provide you with a lot more detail later this afternoon, given his area of expertise. There was not information known about its transmissibility, its severity, how much the vaccines were able to prevent transmission, and severe disease, which are two elements of the vaccine response there, none of those things were known. So it wasn't that there was an overwhelming concern about, based on known information or facts about Omicron, but just a desire to pause, that certainly was reflected in that border decision, to seek more information. And every country in the world was in the same position there, desperately seeking information on a variant that had only become known in weeks and days prior.
Okay. And in some of the scenarios that would have underpinned the modelling that was being done, through all of last year, did the scenario where the complete collapse of the testing regime in Australia featured? Like, was that part of any of the scenarios that would have been considered by the government under the opening up plan?
Not that I'm aware of, Senator.
So why is that? Why would it have not featured? I would have thought worst case scenario planning would have, well, not even worst case scenario, but testing, considering our test, trace, isolate, quarantine was key to opening up, why would the public service in advising the government not have looked at things like the complete collapse of the testing regime and what to do if that scenario occurred?
Yeah, thank you, Senator. Certainly in the early Doherty modelling, I referred to the modelling that was led by PM&C there for the COVID Risk and Response Task Force. There was specific modelling of a more transmissible variant, and it, obviously there were higher case numbers incurred there. There was and it assumed a greater degree of severity, I think, than we have with Omicron, and also lower transmission than we see with Omicron. So there was some modelling there, but the evidence was, and this was also strongly supported by the chief health officers in every jurisdiction, was that the PCR testing system had performed very well under significant pressures during some of the peak waves in jurisdictions in New South Wales and Victoria, when there had been, really significant increased demands for testing in the midst of an outbreak. Those PCR testing systems had responded well and had demonstrated a capacity well in excess of what they were delivering against at the time that modelling was undertaken. And so the numbers modelled were considered to be within the parameters of the capacity of the PCR testing system as it had been demonstrated to be able to deliver to at that point. Also, as I said, the chief health officers and the AHPPC had a strong view that with the case numbers that we were seeing in Australia at that time, and even with an anticipated, if a variant arose that was more transmissible, the preference was for PCR testing as a higher standard of testing, and that rapid antigen tests may become part of a complement of testing, but that would not be the mainstay of a testing response under the PCR testing system. And as I said, I do point this out because it's a really strong factor that the chief health officers in each jurisdiction were strongly of the view that the PCR testing would be what they would continue to rely on and what they wish to rely on because of the increased reliability of those tests. So
is your evidence then that there was no planning done around what actually happened? So when the testing system crashed, as it did in late December, early January, and we had all those waits and queues and 8 hours with people with kids in cars waiting, like that was not foreseen under any scenario considered by the government as part of the opening up?
What I said, Senator, was that the PCR testing was considered, in the modelling that we had done, it was considered that it would continue to be a mainstay of the testing response, that rapid antigen test would play a role, and an increasing role, and the National Cabinet meeting on the 5th of November did publicly canvass that in the statement as well, that had been discussed at the National Cabinet, and there were AHPPC considerations that would apply to the increased use of rapid antigen tests. So there was certainly planning, Senator, for what changes might ensue in the testing regime with increased case numbers as the nation moved through the national response and opened up. But as I said, there the PCR testing system had performed very well with massively increased capacity in peaks and troughs earlier in state. So that
there hadn't been any planning around the failure of that system. I accept it's the preferred system. I accept that it had worked through the rest of the pandemic, but your evidence is there hadn't been any planning or preparation around that system failing as part of the opening up.
Well, certainly, Senator, we also hadn't planned. I'm trying to make a point that there were so many elements that were not known at the time. We certainly hadn't planned that an additional 20% ask of that PCR system would be aligned to test to travel specifications and requirements that were placed on the PCR testing system from jurisdictions in response to opening up, where they stipulated that a PCR testing was required to travel to their jurisdiction.
So wouldn't National Cabinet have spoken about that though? Why was that a surprise?
Well, it only occurred later, Senator. So at the time that you were talking about the modelling and all that planning for subsequent stages of the pandemic, that was not known. That was months later when jurisdictions then said, now we would like a PCR test for everyone travelling to our jurisdiction. The impact of that on the PCR system, that had not been foreseen, that requirement would be placed on the PCR testing system. And it is well known that it placed a massive burden on the testing systems, particularly in New South Wales and Victoria. And both those premiers openly acknowledged and canvassed the extent of the burden on that testing, talking about additional 20 to 25% requirements and testing of their system.
But again, in the lead up to that, like those announcements were made, what did everyone just sit there and think, oh, well, that the system's going to cope with that and we'll just see how it goes?
The system had coped with numbers well in excess of what was contemplated with the national plan, Senator.
But the collapse of the testing system then was a shock to the federal government, presumably. If you hadn't scenario tested, you thought the system would hold up. It didn't, as we all know. So that it was as much a shock to you guys as it was to everyone else lining up in the queue.
Senator, I wouldn't agree with the characterisation that the system collapsed. It was placed under enormous pressure in certain jurisdictions for a specified period of time that, as I said, was associated with demands that were placed on it that had not been anticipated. And had those additional demands not been placed on it, it may well have continued to be able to function, augmented by rapid antigen tests.
You presume.
But for example, the point I would like to make in that regard is that in South Australia, there was an acute period of stress with the PCR testing system, but very quickly that stress subsided and they are now back to their preferred approach of relying on PCR testing for verification of COVID positive cases. So I wouldn't characterise it as a universal collapse of the testing system, but I certainly I acknowledge that the system was placed under enormous pressure
during that time would not say it was working properly.
I've acknowledged that, Senator, there were certain jurisdictions for a particular period of time there when the system was not delivering results in a way that were supporting the adequate COVID response.
Just before I hand the call on, and Senator Davey, could you come to you, I presume, or could you indicate on WhatsApp, perhaps? Now, the Prime Minister said that he first referenced the use of rapid antigen testing when he released the national plan on the 6th of August and said that there would be further work done around the use of rapid antigen tests to facilitate the opening up. Can you just specifically and quickly tell me what PM&C's role in that was, if any? He said further work will be done, preparing for the phases and how rapid antigen testing can be better used in those phases. That was in August.
That further work, Senator, would be led by Health and the AHPPC, and no doubt the Prime Minister was referring, amongst other things, to the commencement of the use of rapid antigen tests in residential aged care facilities that occurred at that time and continued to scale up in the months following.
There's no reference to aged care. So you're saying that it was Health and AHPPC, so just PM&C, you have not had any role in relation to rapid antigen tests in the lead up, like last year? You had no role. That was Health's job, was it?
We work closely with Health, Senator, but it's
I know.
led by Health in that.
But you weren't leading any policy work on it. You weren't advising the Prime Minister on rapid antigen tests, the use of them, what's happening overseas. That's all Health's area.
The advice was provided by Health, Senator, because it's health advice about. It is expert advice on the appropriate use in a health context and a pandemic context about when rapid antigen tests can be safely used.
Yes, but presumably PM&C has also got a role advising the Prime Minister on what the right thing to do is based on health advice, and I'm just trying to understand what role PM&C had, if any, in advising the Prime Minister about rapid antigen tests.
Our advice, Senator, would have been implementing and delivering on the health advice on the use of rapid antigen tests that would have been provided by the Department of Health, the AHPPC and the CMO.
Okay. And to your knowledge, so was that at that point restricted to the use of rapid antigen tests in aged care?
I'm certainly aware that that's where they were being used from August. Mr Neal, is there anything more you're able to add to that?
So we provided advice initially in August, particularly around aged care, because that was where the first those trials, as Ms Frame was saying, happened. And obviously subsequently we, as Ms Frame said, we provide advice on to the Prime Minister on implementation of that health advice and how it would be rolled out.
Mr Neal, you didn't provide any advice around broader use of rapid antigen tests. It was picking up the health advice and then saying around aged care and then saying this is what health is saying.
In August it was, that's right, Senator.
Okay, but has that changed?
Well, it was subsequently, Senator, we've provided further advice on the use of RATs more broadly based on that health advice. So again, around implementation of health advice in terms of rapid antigen testing.
This year?
I'd have to check, Senator, whether it was this year
you
or
don't
not.
recall whether it's this year? It's only 5 weeks in.
It seems like it's been much longer,
yeah,
Senator.
I get it.
We've provided quite a lot of advice to the Prime Minister on the health advice, if I can put it that way.
About rapid antigen tests?
Yes, Senator.
Okay, we might come back to that. Senator Davey.
Thank you very much. Thank you, Chair. Thank you all for attending today. We've had a few goes at trying to get today established, so I really appreciate that it's happening. I want to come back to the rapid antigen testing advice and the timeline for the advice, because I want to really understand it's not PM&C that gives the advice to National Cabinet, nor is it the federal government or PM&C that actually makes decisions based on the advice. So my understanding is previous advice until late last year, the advice to National Cabinet, and Ms Frame, you've said you were a note taker, so I understand you can't disclose the exact discussions of National Cabinet, but you can give us an idea. My understanding until late last year, the advice was still the PCR tests were the preferred tests to be used, and it was only very late last year, I think around November, that the TGA even approved a RAT test for home use. Is that the right sort of timeline?
That's correct, Senator. The point I was making to the Senator and the Chair earlier is that the use of rapid antigen tests has been the primary source of advice on that has come from health experts, because it is about the appropriate use. They're very health-specific questions about when can those tests be safely used. And the chief health officers in each jurisdiction have been, I think it's fair to say, zealous about guarding that as well. So they want to oversee the use of those tests in their jurisdictions, and that is their role, that's their statutory role. So they have been providing advice within their jurisdictions about the use of rapid antigen tests. And then for the National Cabinet, the AHPPC, as a subcommittee of the National Cabinet, consider the appropriate use of rapid antigen tests. And as you say, Senator, the advice from the AHPPC was until December last year that rapid antigen tests were not the preferred testing model. They were still preferring a PCR test, and rapid antigen tests have a place as part of the public health social measures and the test, trace, isolate, quarantine measures, but it was not seen to be the primary testing modality that was preferred, and that was for very strong health reasons on their on their side, in that they did not have definitive information about the severity of the Omicron variant, and were wanting to get more information about the severity of the condition before they changed the testing approach recommended, in case that they were missing positive cases and were subjecting people then to adverse health outcomes because of reliance on a testing regime that was not so reliable. So yes, Senator, that is the case.
So when we first started seeing RATs being used in Australia, I believe, and correct me if I'm wrong, they were first trialled in aged care settings where they're actually health professionals in those settings to sort of guide them. But at what point, and which jurisdiction is responsible for accepting the results of a RAT test as proof or otherwise of COVID positivity or negativity? And at what stage in the timeline did we convert from no, only a PCR test is good enough to no, now we'll accept a RAT test? And I'm acknowledging as well that there are different scenarios. So the Queensland board didn't accept RAT tests as proof of negativity until I think this month. But in aged care settings, it was accepted for health workers to come in with a negative RAT test. So I accept there's different levels. But can you give us a bit of a description of that sort of timeline and responsibility?
Yes. So, Senator, it was the 30th of December that the National Cabinet, in the statement that was released after, announced that they would be moving to rapid antigen tests as proof of COVID positivity. As you say, that was agreed at the National Cabinet there on 30 December, and that then needs to be reflected in the public health orders in the respective jurisdiction. So as you acknowledged, it's within the statutory remit of the jurisdictions, not the Commonwealth, to mandate that different approach. So it was the National Cabinet decision on that date that was then subsequently reflected in public health orders in the respective jurisdictions. But as you pointed out, Queensland had some restrictions, very active restrictions on use of rapid antigen tests and whether they were lawful to use in that respect. South Australia and Western Australia also had similar constraints that were lifted in January and I think late December in South Australia as well. So rapid antigen tests were not even able to be used in those jurisdictions until very, very late last year.
And you couldn't even buy them in those jurisdictions either. Is that correct?
I think, as you said, they were used in some very limited point of care contexts, a point of care test, but not self-tests. That's right. You talked about self-tests where it's evidence of COVID positivity. That's the self-test that is self-administered. That required a public health order to recognise that, and those changes were not agreed and made until 30 December.
And I just want to come back to the impact of some of the border arrangements that have occurred right at the beginning of summer holidays, when Queensland was still required proof of COVID negativity to enter the state, but at the time they were also requiring PCR tests. Have we got any data or modelling to show what sort of impact that had on the pressure on the PCR testing requirements and the laboratories?
Yeah, we would be dependent on the states and territories for that data. Senator, they run the PCR testing systems in their jurisdictions. So all we know is what they've shared with us and what they've publicly acknowledged, which I referred to earlier in my response. The New South Wales and Victorian jurisdiction and premiers were the ones who were particularly affected by that requirement. It was predominantly their citizens seeking to travel to other jurisdictions. And I'd need to check, but I understand the Victorian Premier said it was up to 25% impact on his PCR testing queues, and the New South Wales Premier said something similar, around 20%, I think. And I don't think they sought from people specifically which jurisdiction they were seeking to travel to, but they were just able to aggregate the demand because they did ask people, why are you in this line? And people were able to respond that it was because they were seeking to travel to another jurisdiction. So that test to travel requirement and the demand on the system was monitored there and measured in those jurisdictions.
So is it fair to say that all of our planning and preparation was sort of based on what was the status quo, and then these additional requirements by state governments late in the piece to have proof of negativity to cross borders and things like that, through a spanner in the works of that planning? So it was a case of best laid plans, but then the situation we were in, the parameters were changed.
Yes, Senator. We had assumed, with opening up and additional case numbers, we had assumed significantly increased demand for PCR tests, but not the additional element of the test to travel requirements that had not been foreseen. And as I've just relayed to your numbers, that incurred a really significant additional impost on those state testing systems. Oh, and also the Omicron variant, its transmissibility and the case numbers there that were seen had not been modelled and had not been foreseen by any jurisdiction globally that I'm aware of. But someone might be able to give me some other data, but certainly nothing we're aware of a modelling of a variant as transmissible as Omicron proved to be.
Thank you. That's all from me.
Thank you,
Chair.
Senator Davey. Can I go to Senator Patrick online? And Senator Steele-John, can you indicate to me on WhatsApp whether you have questions for witnesses? Senator Patrick.
Thank you very much, Chair. Just a question to PMC, and unfortunately I can't see exactly who's there, but can someone please describe PMC's current commitment of resources and coordination and to support the Australian Government's COVID-19 pandemic response? So this is within PM&C.
So sorry, Senator, the
The
question
resources
is...
available across PM&C to support the government's pandemic response.
Okay, thank you. Senator Patrick, every resource in PM&C is required at particular times to work on the COVID response. So people are brought in at different points and would have elements, to a varying extent, their workload will move on to COVID matters as it becomes very urgent. And my colleague here is an example of that, where she's been increasingly involved in COVID matters over supply chain. But there's also dedicated teams. I'm sure you're referring as well to dedicated teams who do nothing else other than COVID response, continuously. So there are two branches that Mr. Neil here heads one of the branches, the COVID-19 Health Priorities branch. His team do nothing other than COVID response. There's also another Assistant Secretary who's here with me today, Ms. Rachel Lloyd, who heads the COVID Task Force. I would need to get the exact staffing numbers for you, Senator, of the numbers within those teams, but there are two dedicated branches in that regard that work full-time on the COVID response and have been throughout the entire pandemic.
Yeah, so thank you. I was actually referring to the dedicated teams. So if you could please, perhaps on notice, give some indication or provide an indication of the current FTE, but also the past FTEs.
Yep.
Perhaps over the last 6 months, just to get a feel for how those numbers have changed.
Certainly, Senator, we can get that information for you as soon as possible.
Okay, thank you. Do you have any sort of rough feel for the approximate size of those two teams?
Senator, so my team, which is, as Ms. Frame says, the COVID-19 health response team, it does vary, but it's around sort of 10 to 12 FTE in my team. So that's the COVID health response team. And then, as Ms. Frame said, we draw in expertise from other parts of both Social Policy Division and other parts of the department on specific things.
And the COVID-19 task force?
Thank you, Senator. I've just got some more information for you on that. The current staffing level on that team is 6. You asked about over the last 6 months. For the last 6 months of 2021, there was also an additional team that was headed by a First Assistant Secretary that had up to 10 ASL that was working on the COVID risk and response task force headed by Secretary Gaetjens and leading on the Doherty modelling and the national plan work.
Yeah, thank you. There's a page on your website that which was posted in April 2020 that states the key to Australia's effective management of the coronavirus pandemic is providing accurate, timely information to Australians. We have seen a whole bunch of disinformation, including coming from Liberal and National Party, One Nation and UAP party members. What role does PM&C play in relation to the government's information strategy in relation to COVID-19 and its specific efforts to counter and combat COVID-19 misinformation?
Thank you, Senator. I would immediately respond by saying where that is in a health space, specifically if it pertains to vaccinations and treatments and severity of COVID, where it's health specific, which I assume most of those, most of the misinformation would be, given COVID is a virus. They would largely be responded to within the Department of Health, and the Department of Health would provide briefing on that and have responses there within their department. Is there anything further in PM&C response?
We'd have to check, Senator. I think I understand there has been some work. I think our behavioural economic beta team have also done some work with health on countering misinformation. But as Ms Frame said, it would be principally the Department of Health that sort of lead that or sort of countering misinformation responses. And they've done a lot of work in relation to vaccines in particular, where a lot of sort of COVID information and vaccine information has not only been sort of general information has been provided, but in addition, information in language and also information sort of addressing common misconceptions as well.
Yeah, so there is a bit of information about the beta team, and I think it's Dr. Larissa Bonner doing some work in relation to this. This is just going back a little bit. Does the department have an understanding of the primary sources and promoters of COVID-19 misinformation?
Senator, as I said earlier, my assumption is that this is predominantly in the health arena. It would be misinformation about vaccinations and the nature of COVID and treatments. So that would be led by the Department of Health, but we do work closely with them. But the main source of advice on responding to misinformation, because the experts with the appropriate accurate information would be within the Health Department. And Prime Minister and Cabinet may provide advice from health on that, but we would not be addressing health misinformation, but it would be responded to primarily from experts in the Health Department.
Okay, so I might wait until they appear after you guys, but maybe just to close this out, and this is my last line of questioning, Chair. Has the Prime Minister himself been briefed specifically on sources and the persuasiveness and the impact of COVID-19 disinformation, and if so, when were those briefings provided?
Then Prime Minister, I can't think of a specific briefing on that, Senator. I think it would have been touched on in a range of briefings. So I would need to take that on notice to get you an adequate response on that, Senator.
Okay, thank you. I guess I asked the same question about whether National Cabinet has been briefed on this, because obviously I think this probably cuts across states as well. So perhaps you could take that on notice. So
yes,
sorry.
Last question, Senator Patrick.
Sure. Okay. Can you just tell me the process that's undertaken inside PM&C in circumstances where it is an MP or a senator that makes a statement publicly that might fall into the category of misinformation. How does PM&C respond to that, noting that, particularly in cases where it might involve a government member or senator?
Yet again, Senator, the examples of that I can think of have been responded to from the CMO and the Health Department, because they are about vaccine. They go directly to vaccine misinformation and other misinformation around the nature of COVID. So the lead, as I have maintained throughout this discussion, is health when it is health specific. But if there are some examples you have, anything you want me to look into that was not related to health misinformation, I'm happy to take that on notice and see what PM&C might have provided in that regard.
So just to be clear, if it's an MP that makes or promotes disinformation about health, then it is not PM&C who generally deal with that. It comes directly through the Health Department to the Prime Minister.
It would be contextual, Senator. I would need to take that on notice. I can think of examples where the CMO has directly, in public statements, addressed misinformation and made comments, and PM&C would be aware of that, but we haven't provided direct briefing in advance of the CMO responding to those comments or misinformation where it is known. But okay. As I said, any specific examples I'm happy to take on notice, Senator.
Okay, thank you, Senator Patrick. Senator Lambie.
Thank you, Chair. Can you please tell me how many rapid tests are being manufactured here in Australia today?
Senator, it depends on your definition of manufacturing. There are tests that are being assembled here in Australia, in Western Sydney, so that the parts...
No. Okay, let's just go from start to finish. How many got full manufacturing from start to finish, from bottle to pudding container, all the way through? How many?
Senator, I don't have an exact number on that for you. As you be aware...
Is there anyone manufacturing rat tests here in Australia from start to finish? That's what I want to know.
There are some manufacturers, Senator, who are manufacturing in Australia for overseas suppliers, not for the domestic market at this point. But my colleague here, Ms Tilley, may have some more information for you on your question.
Thanks, Alison. Thanks, Senator.
Do you want to take your mask off just while you speak? Thank you.
Sure, thanks, Chair. To my knowledge, just to reiterate what Ms Frame said, there are a number of Australian companies who assemble, but to take your point, they do import components for assembly from other countries before they then assemble in Australia. So from complete woe-to-go manufacturing domestically in Australia, to my knowledge, there's not any producers right now that do that entire componentry in Australia, manufacture of rats.
There's a company in Brisbane that has the capacity to manufacture rats. We've all known about it for months because I certainly know that they went to your Minister of Health, but they had to take their business elsewhere because of a lack of support from the Australian government. Another Aussie company says their talks with our politicians were lacklustre and disappointing, and they found insufficient government support for local manufacturing. The US supported those Australian manufacturers to open a factory over there, which is now employing 1,500 people. Why didn't we back Australian companies to make rapid tests for our market?
Senator, if I could just make a couple of points just to clarify what might be a little bit of a semantic issue at the beginning. Again, I guess my previous reference was full manufacturer, including the components in Australia. There's, to my knowledge, no current company that does that all in Australia domestically. Your reference to some companies, I think you said in Brisbane or Queensland, who do manufacture and supply overseas, to my knowledge, they don't manufacture in Australia, but they are Australian companies who supply, including through manufacture in other companies, to the United States, as you've mentioned. A key thing here, and then I trust that colleagues from TGA who are appearing later will be able to go into more detail, but the key requirement, of course, for supply of rapid antigen tests to the Australian market is they need to be TGA approved. And so, at least for some of the companies you might be referring to, one of the reasons they cannot manufacture and supply to Australia right now might be that they do not have TGA approval for their products.
So let me get this right. So the TGA approval for our kids to get shots took what, about 8 weeks? Is that right? Or is that wrong? It took about 8 weeks.
I'd have to refer to TGA. That sounds about
Because I find
right.
it bizarre that took that long and we're still waiting for these rapid antigen tests.
Senator, can I just say that the companies in Queensland, and as Ms Tilley said, it is worth confirming with Professor Skerritt when he appears later, but my understanding is the companies in Queensland have not in fact lodged applications with the TGA. So they're still preparing the clinical information that they need to furnish the application and submit the application. One company from Queensland lodged the application and then withdrew it before Christmas because they needed to provide additional information, and they have not as yet lodged a further final application. So the
Was it true that your Minister of Health knew about that these companies went and tried to get through to them months ago? Months ago. Once again, lacklustrous. That's what I'm saying. In September, the head of TGA said they were waiting for a signal from the government before approving rapid tests for the Aussie market. Why wasn't the Australian government more proactive about getting these tests approved last year? We knew we were opening up in October and November. The vaccine numbers were there, but we didn't get ourselves ready to live with COVID at all.
Senator, the TGA...
Why wasn't the Australian government more proactive? How proactive was this? Why don't you tell me what PMC did to be proactive?
Okay, Senator Lambie, I think Ms Frame's trying to answer your question.
Senator, I was going to say the TGA approved self-tests, rapid antigen tests in October last year. So you referred to them saying those in September, they were actively considering applications, they were approved in October. And they had been used prior to that for trial purposes in residential aged care facilities and were the focus of planning in the AHPPC for their future use. And the TGA and Professor Skerritt can talk you through these processes, but they go through processes that are rigorous but very fast, in fact, when they do receive applications, to be able to assure Australians that the tests they are paying money for, or governments are paying money for on their behalf, are reliable tests.
How many manufacturers does Australia need now to keep up with these rapid antigen tests? When will they be set up and available? And the same with when it comes to the shots, whether they're the Pfizer or Moderna. When is Australia going to start manufacturing those?
Senator, Ms Tilley may have some more detail on the rapid antigen test, but there's certainly a lot of work modelling or actually just determining exactly where those rapid antigen tests are going to be sourced from. We have them coming from different places around the world at the moment, as well as I said, some Australian suppliers there who are assembling rapid antigen tests, and there's very active work in government as well to support further production of rapid antigen tests and to assure the supply globally. Ms Tilley, I don't know if you have more to add on that before I go to the second part of the Senator's question.
Certainly. I can give some information both about the work that the Australian government's doing to secure more supplies internationally of rats into Australia and the way the Australian government's helping there.
No, that's not what I asked you. When? Yep. No, I didn't ask you about that. I said, when are they going to start manufacturing them here from start to finish? And the same with the shots.
Sure.
That was a promise from the government with its manufacturing. It's been a promise to start manufacturing in this country since they've been in government. I want to know, when are we going to manufacture the rat tests? Right, when are we going to start from finish? When are we going to have the capacity to do that? And when are we going to have the capacity to pharmaceutically make the shots of Moderna and Pfizer? I want to know when.
Okay, Senator Lambie, let's see if we can allow the witness to answer the question.
Thanks, Chair. Thanks, Senator. I'll respond with some points on rats, and I'll leave the vaccines.
Yeah, sure. More information on mRNA vaccine.
Sure. And look, Senator, I'll caveat up front that I don't have a specific date for you, but I will provide you some additional information on how the government is supporting domestic manufacture of necessary testing, rapid testing for coronavirus. So the Department of Industry is the lead on support, as you said, through modern manufacturing strategy for Australian manufacturing. And the information I have from that department is some recent support that was provided by the Department of Industry, includes to WA-based Avicina Systems Limited, which was funded through the Modern Manufacturing Initiative to develop a low-cost, ultra-high throughput lamp-based screening system for COVID-19, and that technology would provide rapid results with very high precision, determining whether or not somebody was COVID positive. A separate stream of funding went to also WA-based Alkalizer Proprietary Limited, funded through the $30 million commercialisation fund administered by the Australian Government, for the Australian Government by the Advanced Manufacturing Growth Centre, to work with research and industry partners to develop a mass-market saliva-based antigen test to detect COVID-19 in asymptomatic and symptomatic patients within 10 minutes. So those are two examples of Australian Government funding to support domestic development of rapid antigen tests. I will just note, but I'm not best placed to go into detail, there was a media report just a couple of hours ago about the Victorian Government announcing some investment in Victorian-based rapid antigen testing manufacturer. I can pull up that article, but it'll...
I'm actually getting to that.
Okay, Senator Lambie, we are running out of time with these witnesses. Okay. I have a few other senators I need. Ms Frame, did you want to add anything there briefly?
Mr Neal has some.
Can I just ask one more question?
Yes, sure. I'll come back to you. Mr Neal just wants to supplement an answer.
So on domestic mRNA manufacture, Senator, there was an announcement on 14 December 2021 that of a partnership between the Commonwealth Government, the Victorian Government and Moderna to establish a sovereign mRNA manufacturing capability in Australia. So that's on mRNA vaccines, that will produce mRNA vaccines in Australia in partnership with Moderna.
Right. Can you please give the committee a timeline on when that's going to happen? I'm sure the 25 million Australians would love to know that. Right. My last question is this. The Victorian Government just announced they'll be making rapid tests in their state, 3 million tests a week by July. Why is it always the states who have to figure this out and the federal government who throws up their hands saying, it's all too hard, not my job, mate? Why is it that the states are outperforming your PMC? Why is that?
Senator, Ms Tilley's just given you some examples of where the Commonwealth has directly funded and supported development of rapid antigen tests and other COVID-19 medical responses. So we don't agree with the characterisation. The states have a different role.
Okay, but the state of Victoria has given me a timeline, so maybe you can give me a timeline of all that stuff.
Okay, Senator Lambie.
Produced.
Can I just add one thing, Senator? Sure. Just to say that the Commonwealth is directly procuring from a producer in Western Sydney, who, as I said, are assembling those rapid antigen tests and have significantly scaled up their production. That is an Indigenous producer in Western Sydney, and their enterprise and its scale is being significantly contributed to by Commonwealth investment and procurement of the rapid antigen tests that they're producing.
What month did you do that? What month? Was it this year, last December? Because we've been in this for 2 years. Okay. When did you do that?
I need to take that on notice, Senator.
Yeah, you do that. Thank you.
Thank you.
Okay, thank you, Senator Lambie. It is the opposition's turn, but in light of the time, and I know Senator Henderson's first time on this committee, so I'll give you, Senator Henderson, 5 minutes before we have to complete these witnesses.
Thank you very much, Senator Gallagher, and good afternoon to all from PMC. Thank you for appearing today. I just wanted to go back to the pressures that emerged for Christmas and in early January in relation to the PCR testing, the impact of the decision of several states, particularly Queensland, which decided that anyone entering the state, regardless of the fact that they had no health symptoms, was required to obtain a PCR test to go on holiday. Can you just describe in more detail the impact that had on the PCR testing from your perspective?
Thank you, Senator. It was a particularly significant impact on the New South Wales and Victorian systems. And further to the Chair's questions to me at the opening of the hearing today, I pointed out that it wasn't a use of the PCR testing system that had been contemplated in modelling around demand for the PCR on the PCR system in the event of increased case numbers. So we had assumed increased case numbers and modelled that with regard to the national plan and subsequent phases of the national plan, but had not assumed that significant use and reliance on the PCR testing system that we hadn't seen in the pandemic to date. A test to travel requirement domestically had not featured in the PCR testing system over the pandemic up until December last year.
Didn't you have a good basis to make that assumption? Because the rules implemented by the Queensland Government in particular did not accord with health advice. Is that correct?
All I could say, Senator, was that we hadn't assumed that that requirement would be placed on the PCR testing system. So I think it would be best to ask that question to the CMO. Professor Kelly would be able to give you his health view of the relative value of that test. I know up until of those tests that were required, but we know up until that time, as you say, the testing was strongly encouraged for people who were symptomatic in any way or had reason to believe they had been exposed. And they were principles of the public health response and of the use of the PCR testing system that had applied universally across the country to that point, up until the point that the test to travel requirement was instigated.
Ms Frame, Senator Lambie appears to be suggesting that the Commonwealth was not proactive in relation to rapid antigen testing, but contradicts that. Could you just take the committee through the Commonwealth response to rapid antigen testing from perspective from PMNC in summary, please?
Certainly, Senator. So throughout last year, and as I've said, the testing response was still predicated on use of the PCR testing system and a very, very strong preference for that by all chief health officers in jurisdictions. And indeed, as we said, the rapid antigen test not even able to be lawfully used in jurisdictions until December and January in some jurisdictions around the country. In August, it was in the second half of last year that there was increased focus on the potential use of rapid antigen tests, and the Commonwealth were the first instigators there in terms of their use in residential aged care facilities, and that was discussed at the National Cabinet in August, and it was noted that the Commonwealth would be using rapid antigen tests on a trial basis in residential aged care facilities in November, and it's in the statement from National Cabinet on the 5th of November. There was a discussion around more planning on the use of rapid antigen tests in subsequent phases of the pandemic, and that was tasked to health, and the AHPPC would be doing more work on the use of rapid antigen tests, and they were certainly had commenced that work at the point and were working on that, progressing that at the point that Omicron emerged in Australia in very late November, early December. And then, as we know, that was contemporaneous with the test to travel requirement on the PCR testing system, and these things occurred at the same time, that then placed enormous stress on the PCR testing system that had not been, it was unprecedented in terms of the demand for PCR tests. And at the 30 December National Cabinet meeting, there was the decision taken and subsequently reflected in state and territory public health orders that rapid antigen tests could be used for diagnostic purposes where a PCR test was not available, and that a rapid antigen test, a PCR test would not be required subsequent to a rapid antigen test. Thank you, Senator.
Just a couple of quick and brief questions. How many rapid antigen tests have been provided through the RAT community pharmacy program?
I understand you could check your numbers with health later, Senator, but my briefing is as at the 31st of January, it was 2.8 million. 2.8 million have been provided through the pharmacy program.
Thank you. And I also there's been a bit of misinformation in relation to this particular issue, but is it the case that testing for people with symptoms or close contacts have always had access to free tests?
That's correct, Senator.
Thank you very much. No further questions. Thank you, Chair.
Thank you, Senator Henderson. I just have a few questions. I see we're running out of time. So just following on from Senator Henderson's questions, when the Prime Minister and the Minister for Health both spoke of the critical role that rapid antigen tests would play as the opening up or the national plan was implemented, if that was the case, and this was certainly clearly advice to them that it would, and the language was rats will be critical in the opening up, it'll be a critical tool, why then were there such big shortages even in aged care 4 months later? Like, what is the answer to that?
Senator, the Commonwealth, in anticipation of the increased use of rats with opening up and with subsequent progression through the national plan, did procure additional supplies for their own use in aged care, and they will be able to provide more detail on the numbers and when they ordered supplies of rats. But certainly the Commonwealth anticipated that for residential aged care facilities and made allocation for that. I've just forgotten the second half of your question there, Senator.
Like, it's why is there such big chronic shortages even now, like in February, so particularly chronic shortage in January for access to rats for essential workers?
I think the answer to that question, Senator, is simply that Omicron happened globally and had global impacts on the supply of rapid antigen tests, and it happened at the same time. It just burst onto the scene globally, and every country has been experiencing difficulties in sourcing supplies of rapid antigen tests since that time. So we have been successful in securing significant numbers of rapid antigen tests, and the Commonwealth, as I understand it, has provided over 8 million tests to the residential aged care sector. But I would encourage you to check the latest numbers with health. But the issues in January and February have been singularly associated with, or predominantly associated with, global supply issues with rapid antigen tests associated with the Omicron wave that has swept the world.
So again, I guess the question, and it sort of links to the previous line of questioning I had, regardless of the variant. So I know the answer seems to be to everything because of Omicron, but surely there were scenario plans of broad-scale or widespread community transmission occurring as part of the opening up. Is your evidence that even in the worst scenarios that the modelling would have predicted, Omicron was worse? I mean, was the government so sort of underprepared for a situation where everything went wrong? And you were out of supplies, the testing regime collapsed, the hospitals got under pressure, the aged care system closed, people couldn't go to work, supermarket ran out of supplies, transport lines were cut. I mean, was that all just a complete surprise?
The extent of the transmissibility of Omicron, Senator, was not anticipated. We did do modelling.
Under any scenario?
Well, we certainly, as I said, there was modelling about significantly increased demand on the testing system. There was very detailed work done on demands on the health system, and that was the subject of very regular updates to National Cabinet in the last few months of last year in anticipation of the opening up. And that planning has served the nation very well in terms of the preparation that health systems were able to make, and would also point out that the hospitalisations and ICU admissions have not been at all in line with the modelled scenarios, the worst case scenarios. They have been lower, in line with the evidence about Omicron and its reduced severity. But the planning for a worst case eventuality in the health system and increased pressure on the health system was certainly undertaken. There was significant investment in primary care channels, and there was a lot of work done there, Senator, so that it was modelled. Those increased impacts were all modelled. There was...
Why did it all go so bad in January? Like, it doesn't fill me with much comfort that the answer to what happened to Australians over December and January is the evidence today is we didn't really see that coming. And I don't know whether there's another explanation for it, but it would seem odd to me that 2 years into a pandemic the government wouldn't have said, what if all of these things happen and this was the result, how do we respond?
I think my evidence today, Senator, has been that there were many things that we anticipated and planned for and put in place contingencies. So all the health system capacity work and securing supply of rapid antigen tests for residential aged care facilities,
But it hasn't
response
gone
to
well in
essential
aged care,
workers.
has it?
Chair, can I just raise a point of order?
Yes, Senator Henderson.
Thank you very much, Chair. Look, I just wanted to, raise the concern that the evidence of PM&C is not that we didn't see this coming. So I just would ask that the record
What is the point of order? What is the point of order, though, other than just a comment?
The point of order is that I'm raising concerns about the mischaracterisation of the evidence given by PM&C.
Okay,
Chair.
thank you, Senator Henderson. I don't think there's a point of order, and Ms Frame is just responding to that.
Thank you, Senator. So I was just pointing out that there was a lot of planning done. It served us well in terms of the response of health systems and the response of the National Coordination Mechanism in dealing with supply chain issues and some of the other issues that you've raised. But the part that was not anticipated anywhere around the world that I'm aware of is the extent of Omicron, the transmissibility of Omicron. And there were additional elements in Australia, as we've discussed, around the demands on the testing system that had not been a function, had not featured in any earlier stage of testing throughout the reliance on PCR testing in all stages of the pandemic to date. There had never been that additional 20 to 25% demand for test to travel requirements. So even our modelling of significantly increased demand on the testing system had not contemplated that additional requirement.
Again, with National Cabinet, that I don't know that that's a suitable explanation, that you all sit around the table, you all know what was happening as part of the opening up, and now it seems that your evidence is, well, it was things the states did that caused everything basically to fall apart in January.
No, I think, Senator, my evidence is that there was a lot that was planned for, but there were a few elements, acknowledged a few elements that were unforeseen. But I think the National Cabinet, in meeting very regularly over that period, has responded very quickly to all of those issues as they have become evident.
In a reactive way, they've had to respond as opposed to being planned.
There's an extent in a crisis, Senator, to which you have to respond to elements that had not been anticipated. A lot had, but there are elements that will always be unanticipated and need that crisis response. And I think the National Cabinet moved very quickly when additional information became known and was available.
My final question is if that was the case, then as Omicron went into other like countries like Australia, they didn't face the same issues that we faced here in December, January. Like, you know, when you look at what was happening in Canada and the UK and America, where you were seeing, you know, huge increases in transmission and all the rest of it, you didn't see the, you know, no way to access a rat, the testing regime fall over, the supply chain in supermarkets, things like that didn't appear to be as widespread as they certainly were in Australia in those months.
Well, I think they're certainly, well, from what we read international updates every day, Senator, there are significant issues in those countries. And it's also, so they have experienced to a significant extent issues with essential workers, supply of rapid antigen tests in January, and their supply of rapid antigen tests at the onset of Omicron was a function of the increased case numbers that they had going into the Omicron wave as well, whereas in Australia, as you know, we had lower case numbers with Delta. So there are quite significant differences there, but in terms of the experience with Omicron and the impacts that has caused in many similar economies across the country, I think there's more similarities than differences there, Senator.
Okay, well, I no doubt we will continue this at estimates in a week or so, but thank you for your time today. I'm sorry, we've just got a smidge over. The committee will...
Can I just put an example on notice, as was invited to by PM&C?
Yeah, I can't hear you very well, but what are you asking to do, Rex?
Just to put on notice, as requested by the department, just one example, Mr Craig Kelly made an announcement about children, or a recommendation about children not getting vaccinated. It's clear the Prime Minister knew of that because there was talk about his removal from a committee, and he revealed that he'd had high-level discussions. So I'd just like to understand the process in that instance of how the Prime Minister was notified and how the department handles those sorts of, or in this instance, that event.
Thank you, Senator. We'll take that on
Okay.
notice. Thank you.
Thank you.
Thank you.
She got that. Thank you, Rick. The committee will suspend until 2 o'clock when we'll come back with the Minister for Aged Care. Some issues, but I think all worked through. Thank you very much, everybody. I now welcome the Senator, the Honourable Richard Colbeck, Minister for Senior Australians and Aged Care Services, and representatives from the Department of Health, including the Chief Medical Officer and Lieutenant General John Fruin, the Therapeutic Goods Administration, and representatives from Australian Technical Advisory Group on Immunisation. Minister, would you or anyone else like to make an opening statement before we move to questions?
I don't, but I believe Lieutenant General Fruin does.
Yes, just before General Fruin makes an opening statement, Chair, can I just explain that Ms Shakespeare and I will be doing a sort of a double act as Secretary. I had some surgery before Christmas, had a lot of complications, I'm only back at work yesterday, having a long period of leave, so Ms Shakespeare and I will be sort of dual act secretaries.
Okay.
Yeah.
No problem. Thank you for attending today, Professor Murphy. General Fruin.
Yes, Chair. Thank you. Good afternoon, and thank you for Lieutenant General John Fruin, Coordinator General of the National COVID Vaccine Task Force. Good afternoon, and thank you for the opportunity to make a brief opening statement. I would like to start by acknowledging the traditional owners of the land on which we meet and pay my respect to elders past and present. I am pleased to report that the national vaccination program has continued to make significant progress since I last appeared before this committee. We have started 2022 in a strong position. Australia is now over 90% fully vaccinated, and we are one of the most vaccinated countries in the world. 95.6% of Australians aged 16 and older have now received a first dose of a vaccination, and 93.5% are fully vaccinated. All states and territories have now reached 80% fully vaccinated and 90% first dose. We have the 8th highest vaccination rate in the OECD and continue to see progress. Our vaccination rates are higher than our closest neighbours, including New Zealand, and ahead of many other advanced economies, including Italy, France and the United States, to name a few. Our booster program is also performing very strongly. Over 8 million Australians have already received their booster, which is more than 50% of the eligible population, noting that around 4 million, or half of those yet to receive a booster, only became eligible this week. Our vaccination program has demonstrated that it can withstand shocks and challenges, as we have quickly responded to the unexpected threat of the Omicron variant. With over 151 million doses ordered, we have the resources needed to respond to current and future challenges. In the month of January, the vaccination program delivered over double the number of doses as the month of December, up from 3.4 million to 7.2 million. I want to thank our Vaccine Operations Centre, including the Urgent Supply Squad, that supported transfers and deliveries to meet vaccination demand over the holiday period. I also want to thank our logistics partners and the hard-working teams in warehouses, driving trucks and managing supply who ensured vaccines were delivered where they needed to be across the Christmas and New Year period. More than 18 million booster doses were in fridges or delivered to sites by the end of January 2022, including record delivery weeks. This ensured there was more than enough vaccines for those who came forward. On the 20th of January, the program achieved a record high point, with 353,190 doses administered into arms in a single day. There are more than 10,000 points of presence across Australia where you can take up your vaccination. Commonwealth channels, including GPs and pharmacists, delivered over 70% of vaccinations in January, up on their overall program rate, which is averaging 62%. Thank you to the GPs, pharmacists, nurses and vaccine providers that continue to work over the holiday period to ensure these record vaccination rates and our strong protection against COVID was maintained, even if it meant sacrificing time with friends and family over the holiday period. Over 2/3 of Australia's over 70 population have received a booster dose, and I hope to see more Australians of all ages coming forward to protect themselves, their families and their community. Efforts to provide boosters to residential aged care facilities and shared disability accommodation sites have been our highest priorities. We are continuing to work to make sure residents in these sites have the opportunity to get a booster and maintain their protection from COVID. 99% of residential aged care facilities have received a booster clinic, with the remaining small number delayed due to factors such as COVID outbreaks, and are scheduled to receive one in the coming days. Second visits will also be offered. Over 1,780 disability sites have been completed, and over 1,630 sites are scheduled for booster clinics shortly. New data on NDIS participant vaccination rates is now being published, and I acknowledge the support of the Disability Advisory Group in guiding this next step in our efforts to provide transparency and accountability to the vaccine program. We've also seen a positive start to our vaccination program for children, following on from our 12 to 15-year-old vaccination rate, which is now 83.7% first dose and 76.7% fully vaccinated. Australia was in the top few dozen countries to commence its children's vaccination program. Over 40% of children aged 5 to 11 have received a vaccination. This is faster than the vaccination rates of the same group in countries like the United States, Germany and Israel. There was sufficient supply across vaccination sites last month to offer all children a first dose by the end of January, ensuring children have the opportunity to be protected before they return to school. A communications campaign has been developed to support this rollout, and we encourage parents to come forward and book appointments for their children. We have also made good progress in reducing the gap in vaccination rates for Indigenous Australians, with 81.8% of Indigenous Australians receiving a first dose and 75.8% being fully vaccinated. The gap in vaccination rates has closed by more than 12 percentage points during the implementation of our accelerating Indigenous vaccination plans since mid-September last year. The success in each of these areas has been a result of the partnerships that have been developed across the program, and I thank everyone who has worked with the vaccine program and will continue to work with us over the months ahead. I continue to strongly encourage people to continue coming forward for their boosters. There is more than enough supply, more than enough sites, and bookings are available for you to get your booster protection. Thank you again for the opportunity to make this statement, Chair, and I look forward to your questions.
Thank you very much, General Fruin. I wonder if that could be provided electronically to the committee so that we can accept it, but also so that, although you've read it, so it doesn't matter about that, but so that people can refer back to it. It's a lot of numbers in there. So if that could be done, that would be appreciated. I'll just remind committee members that we have the Minister until 4 o'clock. So if you have questions for the Minister, that this is the next time, and then the department and relevant agencies are staying on after that until 5:30. So, Minister, thank you for joining us. In the week of the 14th of January, there was 1,107 active outbreaks across aged care. There was more than 7,000 active cases of COVID amongst residents and staff in aged care facilities. The sector leadership was crying out for assistance, for staff, for boosters, for PPE. Some were asking for the Defence Force to be brought in to help care for elderly Australians. Do you still think it was appropriate to attend the cricket?
Thank you, Chair. I'm very careful to balance and acknowledge the different elements of my portfolio, and all of during that week, and including that weekend when the test match was on in Hobart, and on the day of the first day of the test match, I spent the predominant part of the day working on the aged care outbreak. In the morning of the 14th, the first discussion that I had was with Lieutenant General Fruin and his team about the work that we were doing to bring forward the vaccination of residents and receiving their booster shots. It was a very important part of what we've been doing to protect senior Australians in residential aged care. I then went into a specific meeting that I'd called myself with the department to deal with the very issues that you've just been talking about, Senator. We had been meeting with aged care providers. I had a meeting with Peaks during that week. I'd also had a meeting where we invited aged care providers across the country generally to come and talk to me and the department about the issues that they were facing and work through the particular issues as to how we might manage them. And I did the same thing on the Friday, and on the Friday afternoon at about 3:30, I had a meeting with the chair of the Aged Care Advisory Group, Michael Kidd, to talk about the work that they were doing, providing new advice to the sector, and to also receive a briefing on a conversation that the sector had, that they had the CMO and Professor Kidd, in relation to what was happening with booster shots in Israel. So I did make a specific decision about the balance of my portfolios. The test match in Hobart was a significant event for Tasmania, obviously as Minister for Sport as well as Minister for Aged Care Services and Senior Australians. I had to be conscious of that as an issue, and I was very cognisant of the circumstances that the sector was in. In fact, all through that weekend I continued to work on matters relating to both of my portfolios, but particularly aged care, even though it was a weekend and also I was attending the test match. So it was a decision that I made. I have to stand by it and live with it, Senator. Other people will make judgments about it, I'm sure. Plenty already have. The opposition have made a strong point of criticising me for it, but I would note that there were other colleagues there from other parties, including the Shadow Minister for Agriculture, who had just left Mr Albanese's regional tour of Queensland to ensure that she could be at the cricket. So I wasn't the only one. Other people will make their judgments, but I can assure the committee and everyone else that I'm very cognisant of the balance between my portfolios, and I continue to provide every effort in the interests of assisting the aged care sector through the current circumstance.
So you stand by your decision to go to the cricket then?
Well, Senator, it would be hypocritical of me not to.
Sorry?
It would be hypocritical of me not to.
The Prime Minister said your attendance failed the pub test and he could understand the criticism that was being levelled at you. Has there been any consequence for you prioritising cricket over the crisis in aged care?
Well, firstly, I don't acknowledge or accept the characterisation that you put that I prioritised the cricket over aged care. I didn't. I continued to work on both things over that weekend. Continued to pay attention to aged care. In fact, as I've already indicated to you, continued to work specifically on the management of the genuine issues that were being felt in aged care for most of that Friday in particular, but also over Saturday and Sunday. Bearing in mind it was a day-night match, it wasn't a day match. So, and I can understand the Prime Minister saying, and many people in the community, without making the judgment. I understand that, but I made the decision, and therefore it would be hypocritical of me not to stand by it now.
But in terms of consequences for you, there isn't any?
Well, Senator, I think that the commentary that's come on the back of it is a significant consequence. Whether I believe that was deserved or not is another question. As I said to you a moment ago, I'm very cognisant of my portfolios and the required balance. I take it very seriously. I continue to do that. And will continue to do that. People will have their perceptions about various activities, but as I indicated to you, the Ashes Test match in Hobart was a historic one. It was the first ever Ashes Test in my home state of Tasmania. I'd worked very closely with Cricket Australia over many months to ensure that the actual tour could go ahead. And as I indicated, there were other colleagues who likewise were excited by the concept of the test match. Well, Senator, when the opposition leader is conducting a tour of regional Australia, and the Shadow Agriculture spokesperson says, "I don't care what you think, I'm going home to the cricket." I think that because of the importance of it, granted, it's in her electorate, but it's a significant event for Tasmania, being the first ever Ashes test. I think that gives some demonstration of the importance that was placed on it in Hobart and also in Tasmania. I made a judgment call. I have no option but to stand by that and take the criticism that comes from it.
So, Minister, in the time that you've been aged care minister, 1,438 people in residential aged care have passed away from COVID. It's probably higher because I'm using departments' figures that they issue once a week. Thousands of workers have been unable to work either because of the lack of availability of rapid testing or they were sick with COVID. Thousands of others have had to work double shifts, horrendous stories of 16-hour days, families devastated because their loved ones are locked down and not getting the care that they deserve. The emails I've been getting are simply devastating. I presume you're getting the same ones. Why should you keep your job when this is the result of what's happening in aged care right at the moment?
Well, Senator, as I've said to you, I take my responsibilities in all of my portfolio areas seriously. I take all efforts to appropriately balance the activities that I undertake across those portfolios. I continue to work assiduously and pay attention to the elements that require attention. And as I've indicated to you today, on the days of the test match, I wasn't just at the cricket. I was actually working the problems with the officials in the department to work to manage the issues that were working in aged care. So it wasn't one thing or the other. I was actually working on both, and where I needed to pay attention and provide effort towards supporting the sector in aged care, I specifically did that, including some specific meetings that were called to actually manage those things. So I don't accept your characterisation. I continue to work to balance in the interests of my portfolio responsibilities, and I quite genuinely continue to do that.
So 2 years in, and we've got a system in complete crisis. Do you accept that? Do you accept that the aged care system at the moment, residential aged care system, is in complete crisis?
No, I don't accept that it's in complete crisis, Senator. I know it is certainly working very, very hard to manage the impacts, particularly of the Omicron outbreak. But my view, and the data actually supports that, is that the sector is performing and has performed exceptionally well in the work that it's doing. I think it's very, very difficult. The workforce is extremely tight, particularly because of the transmissibility of Omicron and the impact that that's had on the availability of workforce. And of course, we've at a situation where you've got 4.2% unemployment, you've got similar issues working through the health system more broadly, and aged care, health are all drawing for the same pool, which is why Minister Hunt, myself, the department, are all working this issue continuously to try and ensure that the resources that need to be available are available in very difficult circumstances to the sector so that they can continue. And so that's what we're doing all the time. That's what I was doing on those days as well, and have continued to do in the period since, and quite frankly all through the Christmas break. The work that was done by the department at the Victorian Aged Care Recovery Centre, and of course General Fruin and his team in bringing forward the booster vaccination program has been significant, and we've been meeting on that on a daily basis over the last couple of weeks to ensure that we can actually bring those boosters forward, and that's resulted in the 99% visitation rate to aged care facilities across the country that General Fruin's just talked to the committee about. So, we've been working this problem the whole time and dealing with the circumstances that have arisen that the committee's been discussing today, including some of those that have been outside the parameters of the modelling that's been done.
So, Ms Colbeck, it might have been a long time since you've been able to be in an aged care facility, is that right? Just with all the lockdowns?
As Minister, being cognisant of the issues, it's a little while since I have been physically in a facility, but over recent weeks I've been convening meetings with providers from across the country directly. And so in that period of time I would have spoken to hundreds of providers who have participated in those calls, and part of the agenda for those forums for them is to put any particular matter that they want to put to me and to the department so that we can address those circumstances in particular.
So they're not describing a system in crisis to you?
Well, the circumstance for the sector right now is extremely difficult, Senator. There's no question about that. You've got some facilities where there have been significant infections amongst staff, and that's impacting on their staffing capacity. And as you've indicated, there are staff members who are working double shifts, they're working longer shifts, and they're all doing that in the interests of the residents that are working for them. And so there are significant impacts of this particular phase of the pandemic that are making it extremely difficult. But even in those circumstances, if you look at the broader the infection rate of residents in residential aged care compared to, say, 2020, it's a twelfth of what it was in 2020. So the work that's been done by the providers, the work and advice that's been provided to them by the government, the Aged Care Quality and Safety Commission, the research and advice that's come out of reviews of previous outbreaks in other facilities, the requirement for infection control leads in every facility, the screening programs that are in place for anyone who comes in or out of an aged care facility. All of those things have combined, despite the very, very difficult circumstances, to see the sector performing, I think, very admirably in an extraordinarily difficult circumstance.
Okay, I'll need to hand the call on, but I just have two case studies that have been sent to me in the last day. One from somebody whose adult child works in aged care, and this is the situation they outline. After a 14-hour shift in a large ward with a COVID outbreak, they worked with 1/3 the staff complement with an RN for only 2 hours. She did her best to show the two AINs basic procedures before she was called to another emergency in the ward. They did their best with kindness and compassion with 48 residents, some very sick with COVID, just doing the basics, making them clean and comfortable. Sometimes all we can do is hold their hand, breathe with them for a few minutes before answering the next buzzer. Like so many others, that person had to go back there the next day for 8 days straight. There's outbreaks across a number of wards. The staff are working under incredibly difficult circumstances.
Senator, the staff are doing a magnificent job in extremely difficult circumstances.
Yeah.
They are doing a magnificent job. And we, as government, are providing all of the resources that we can possibly muster to support them to do that.
So you maintain you are doing everything you can, and you did everything you can last year to prepare the sector for what is happening now?
Senator, we have continued to provide advice and are continuing to do that. In fact, there's additional work that's being done by CDNA as we speak, and then there's a number of pieces of supporting work that will flow from that to the sector, because one of the other elements that we haven't discussed yet today is the very, very concerning issue of isolation of residents as a part of this process, which is probably one of the key indicators of the delicate balancing act that we have here in trying to protect people in residential aged care from the ingress and the spread of the virus, and ensuring that they maintain appropriate contact with family and loved ones for a range of other reasons. And so there is work being done on that element of the transition process right now. So we have worked with public health officials, the sector. We've scanned what's happening in other parts of the world. We continue to do that. I've referenced the conversation that we've had with the Israelis regarding the next cycle or next potential cycle of boosters, so that we can understand how that might work. And we continue to do that all the time. We've provided advice and reports from the previous outbreaks so that providers can understand how to better manage their facilities. And as I've said to you, that's borne out in the facts of the way that the sector is actually performing right now, despite the very difficult circumstances. So if you look at 2020, 7.2% of COVID cases were in residents in residential aged care. Recalling 2020 as vividly as I did, not many of us would have thought that there were 28,422 cases of COVID nationally in 2020. 2,051 of those were in aged care. So far this year, there's been over 1.8 million cases of COVID in Australia. And just over 10,500 of those have been in aged care, which is 0.58% of cases. That says to me that the sector, despite all the difficulties, is performing so much better. In fact, it's 12 times less than what it was in 2020. The value of vaccination, the improved screening processes that we've worked with the sector on, through things like the visitors code, the advice that we've provided to the sector in respect of infection control, the requirement that we asked the sector to put in place infection control leads, the training that was provided to facilities in conjunction with the states for infection control, the establishment of the VARC and VARC-like facilities in other states around the country. All of those things have combined to see the sector relatively to 2020 and the performance that we're seeing today, despite the extraordinarily difficult circumstances that we're seeing with the transmissibility of the Omicron outbreak. Now, if you think about the level of transmissibility of Omicron versus the previous strains of the virus, you might have expected to see so many more cases in residential aged care. That hasn't occurred. The incidence of cases in residential aged care was in fact more last year than it was this year. So the improvement, it's about the same, it's 0.6%, but the sector is performing, I think, extremely well, despite the extraordinary difficulties of the Omicron wave.
It sounds like...
And can I say that, Senator? I send my thanks and my congratulations to the workforce, who I know are working extremely hard, and your example is but one of many, but also to the providers themselves who continue to work extremely hard in the interests of the residents.
I think there's a fair bit of work that's gone in there to trying to put a positive slant on what's happening in aged care, to be frank with you, Minister.
Senator, they are simply the statistics. That's all it is. That's all I'm quoting to you.
There are outbreaks in nearly half of all residential aged care facilities.
Yeah, that's right, Senator.
There's nearly 10,000 cases in residents.
Senator,
they're isolated, they're locked down, they can't fill shifts, there's not adequate RN support. They're the majority of deaths that are occurring. You know, it's over 657 deaths in aged care.
They're not the majority of deaths that are occurring. That's not the case. And that figure has also reduced significantly from where it was in 2020. So the benefits of things like, as I said, vaccination have made a big difference. And I'm not denying that it's extremely difficult. out there in aged care right now. I talk to the providers every week. I talk to the peaks every week. And I talk directly to providers themselves. So they give me that feedback. But what we're doing is working on how we assist them to resolve the issues. And that they face, we all face. And that's what I'll continue to do.
But your presentation is a pretty rosy analysis of the stories that I'm hearing and the stories that are in the media and the stories that families are telling me, I have to say.
I'm not trying to downplay the experiences of the workforce or providers at all. I'm just putting on the record the fact that they are performing really well despite the difficult circumstances. And I think that should be acknowledged. I think that there's been so many attempts to talk down the aged care sector. They've worked extremely hard and the statistics, and that's all they are, demonstrate that all the work that they've done, the things that have been done by them in conjunction with government, are having a positive effect. It doesn't mean that there won't be difficulties. The outbreaks, as we've seen in previous waves of infection, run in line with infection in the community. As the infections in the community grow, so do infections in residential aged care facilities. We saw that in 2020, we saw it in 2021, and we're seeing it again now in 2022. But if you look at the statistics in the context of the performance, the sector is, despite all of the very, very significant difficulties that they're facing right now, they are doing well. And we continue to work with them to provide the resources and the support, and we're looking at every avenue constructively with them to support them to manage through this particular wave.
Senator Davey, you have the call.
Thank you, Chair. Thank you, Minister, for appearing today, and the TGA and the department. Most of my questions are actually for the department, so forgive me, Minister. I might bypass you at the moment. I just want to get, we heard earlier from PMNC about the approval process for rapid antigen testing. We've heard throughout this pandemic the importance to listen to the science, the importance to listen to the health advice, and the importance sort of not to jump the gun to have approved processes, particularly when it comes to things like the vaccination and tests. Can you please explain? We've also heard today that the Prime Minister quite rightly acknowledged, I think in August last year, that rapid antigen tests would become part of the mix and would become part of, I think it was phase 3 and 4 going forward. But my understanding is rapid antigen tests weren't approved for home use, and the advice for home use was not given until late in the year, November or December. So can you explain to me why ATAGI and the AHPCC were reluctant or did not give advice for home use of rapid antigen testing until such a late stage?
Senator John Skerritt, Deputy Secretary, Department of Health and Head of TGA. It was actually TGA's advice, although AHPPC was an input to the public health guidance on why it wasn't appropriate for Australia, say in April or even in May, June last year, to have widespread home use rapid antigen testing. And the reason why it was quite inappropriate, in fact dangerous, had we had home use rapid antigen testing in early and mid 2021 is that half of them, maybe more, would have given the wrong answer. And so you would have had people with false positives, and in many, you also would have missed a significant number of infections. And this was at a time when we didn't because in early 2021, it's only now less than a year still, since we've had the vaccine going into people's arms. We're still on that curve of getting the population vaccinated, and we're also in a world where we were individually contact tracing. And when you have a low prevalence of cases in the community, if it's only 1% of those who are being tested who are positive, you have 50, 60, 70% of results from rapid antigen tests just plain wrong. False positives and a few false negatives. In the world we have now, where sadly the proportion of people who are infected with COVID is much higher, there are statistical reasons why the reliability of rapid antigen tests is much higher. So that's why they were quite appropriate for New York in April 2021, but totally inappropriate for Australia in April, May, June 2021. The advice on the rapid antigen test went out actually in September last year. There were 13 approvals during October, and from 1 November 2021, where we did have a reasonably high, very high, as the Minister has said, vaccination rate in Australia, where contact tracing processes in many of the eastern states in particular had changed, and where we were integrating rapid antigen tests and self-testing with PCR testing, for example, recommending that symptomatic people and immediate family contacts of symptomatic people go to public health units for PCR testing, we had that framework in place. But this has been portrayed as some, the regulator was asleep or lazy or something like that. No, it was deliberate, because it would have been dangerous had we had 50, 60, 70% of false positive results from COVID testing in Australia 12 or even 9 months ago.
I think it was Senator Lambie who earlier quoted you as saying, Mr Skerritt, that you hadn't approved any rapid antigen tests because you were waiting for a political signal.
Not the word political.
Is she putting words in your mouth, or what was your actual position? So
the word I used was a signal from government, because the advice to government comes from AHP, I get into the acronym soup, I'm sorry, into AHPPC, which are all the state and territory chief health officers chaired by the chief medical officer, and they were having input from the diagnostics, the testing experts, such as the cDNA, such as the Public Health Laboratories Network and so forth. And so they were very aware of this problem, that 50% or more of the results would be garbage if we went into self-testing at a stage where we had very low disease prevalence and were wanting to do individual contact and individual venue tracing. And so they are advisors to government. So in that sense, it was a signal from government, but it was, as always throughout the pandemic, based on the best health advice to government.
It's Professor Paul Kelly here, the Chief Medical Officer. So just to add to Professor Skerritt's comments there. So as Professor Skerritt has mentioned, there's a number of advisory groups to either to me as Chief Medical Officer, or to the Minister for Health, or indeed through to National Cabinet in terms of the Australian Health Protection Principal Committee, that are involved with these types of decisions. It's not an easy decision, and as Professor Skerritt has mentioned, there are two technical groups that advise the AHPPC. One is the Public Health Laboratory Network, the other one the Communicable Diseases Network of Australia, and they have made 4 revisions to their advice in relation to rapid antigen tests. The first was on the 9th of October 2020. That was the initial document, and as Professor Skerritt mentioned, there was a consensus by those technical advisory groups that in the context that Australia was in at that time of low community transmission, rapid antigen tests were not the best way of diagnosing COVID-19 in the Australian context at that time, but they did recognise that there were certain times and places where they could be usefully employed, and that was around the time when the initial TGA approval of point-of-care testing, so that's as used by a health practitioner and supervised by a health practitioner, came into play. That was revised again substantially on the 11th of August 2021 with updated principles, requirements and recommendations for use, as we were in that Delta wave at that time, and again on the 16th of December 2021, particularly then incorporating the changes that Professor Skerritt has already mentioned in relation to the Therapeutic Goods Administration changes on self-administered rapid antigen test use. And then the final one, and this is the current one, in the last week, there's been a further update of that advice, which related to a request from National Cabinet on the 5th of January to update that advice. And I'll quote very specifically here that at this time, so this was the major change that was made in January, at this time, in the context of widespread community transmission, PHLN and CDNA recommend deployment of RATs, a rapid antigen test, to enhance and preserve laboratory-based testing capacity. But all throughout that process, that balance and principles have been constant. And the particular one is in the context of low community transmission, as Australia has been in for the majority of the last 2 years, rapid antigen tests do pose problems in terms of false negative and false positive tests, and that the PCR testing arrangements are and remain the gold standard for diagnosis. So I think it has its place absolutely in the context we're in now. It did not previously have such a place except for very specific places of high risk, such as in aged care facilities, and the Minister has already gone through that in some detail.
Thank you, Professor Kelly. That also brings me to how much is too much RAT testing, because what we are seeing currently, school students in New South Wales and Victoria are being required to test twice a week. Some employment places are requiring their staff to test daily. Others are required to, people might be required to test for their own workplace, but then they're required to test again to enter another workplace. And I'm just sort of, my question is daily rapid antigen testing potentially overkill? Is the 2 times a week for students suitable, or is that underdoing it? Particularly given that we're hearing that there are false readings from these rapid antigen tests, and the PCR is still the gold standard.
So thanks for the question, Senator. A number of elements there. I think, first of all, we are, as the Minister has already mentioned, in this time of high community transmission right throughout Australia. And so there have been changes in the way, necessary changes in the way that we've been able to continue functioning as a society in a different way than we have previously in the last 2 years of the global COVID-19 pandemic. To take schools as an example to start, there were some principles that were asked from the AHPPC to National Cabinet. These have been published in the past about how to keep schools operating safely, as safe as possible in the environment in which we are now. And so the last of those was published on the 15th of November. Since then, we were asked to supply some advice to National Cabinet in relation to the questions you raise in terms of schools about surveillance, whether that's ongoing rapid antigen testing regularly throughout the week for teachers and for students, as is the case in ACT, New South Wales and Victoria, or so-called test-to-stay approaches, as is the case in South Australia, for example. And that was put to National Cabinet, and we've talked here before about where that advice sits within that context, so I won't go into any further detail, but that advice was given. There was I can fairly say, rigorous discussion about those matters within National Cabinet, and then individual states, education and health departments made their decisions based on that. But what was very clear and agreed at that time from AHPPC and all the premiers, chief ministers and the Prime Minister at that point, and education departments around Australia who were involved with this decision, is that the primary purpose was to get schools back. get them back, get kids in the classroom for all the reasons, which is much wider than an issue of the COVID-19 virus. We know that's the place where kids develop social skills, they learn, it's best for their health, their physical, mental and social health and well-being. And so that was the primary purpose of what's been arranged. Different states have made different decisions about how to achieve that purpose. In terms of other workplaces, so that was again some very detailed work that was done both by the AHPPC and the National Coordinating Mechanism, which brings together discussions with industry, discussions with unions and so forth, for the particular issues that we have faced in the last month in Australia around supply chains, first of all, to keep food on the shelves of supermarkets. So there was a range of discussions there about furloughing times in various workplaces. We actually started with aged care, as the Minister has mentioned, healthcare, and then widened that to areas of essential work more broadly, about how we could safely modify our test, trace and isolate and quarantine approaches, including the use of rapid antigen tests, so that we could keep society moving in this context.
So Labor had a policy, although I do note that Mr Albanese seemed to walk back from it on the weekend on the Insiders program, but their original policy was free daily RATs for everybody. Is there any medical advice that supports RATs being provided to everyone in the country for daily use and daily testing?
Minister, maybe this might be for you to start.
Yeah, well, look, I might start there, Senator Davey. I think it's important to note, in the context of the broader decision-making in relation to the utilisation of rapid antigen tests, that National Cabinet, that's Labor, Liberal, state and territory leaders and the Commonwealth Government, made a collective decision in relation to the utilisation of rapid antigen tests and their availability. It wasn't obviously based on the advice that was being provided to them by our health officials, but it was a national decision that was made by state, territory governments and the Commonwealth Government at National Cabinet in relation to the use of rapid antigen tests. You might criticise the process of National Cabinet in some circumstances, but in this circumstance, that position is the one that's being applied nationally by all states and territories in relation to the supply of tests. If an individual is symptomatic or a close contact of a positive case, they can go to a state testing clinic and receive either a PCR test or a rapid antigen test in accordance with that decision of the National Cabinet. So that was the genesis of the process by which this has occurred. I don't think you could actually say that it was necessarily a political one, because it was one that was agreed by leaders of all political persuasions in government across the country, and has continued to be applied off the back of that national decision.
Minister, Senator, if I might add, so I'll go back to that document I mentioned, the Public Health Laboratory Network and the Communicable Diseases Network of Australia, the technical experts in public health and in laboratory science for us. One of their principles states, and I'll quote, "Rapid antigen tests may be used for screening purposes at an interval sufficient to mitigate the reduced sensitivity of the test. This interval is test and prevalence specific. Therefore, a set interval cannot be applied across all such devices or all circumstances." So there's some technical terms in there, but what it basically means is it is context specific, both to how much virus is circulating in the community at a particular time, and the context of the workplace, for example, that you're dealing with, or a school or other place. So it depends on the risk of not discovering someone has COVID early enough, and that goes to issues within aged care, for example, very high risk setting, vulnerable patients. We've talked about that, vulnerable residents. That would be very different to a trucking company, for example, where missing a positive test for a day for an individual single truckie that's out on the road most of the time by themselves in their cabin with very little interaction with the community. So it is quite context specific, and all of the other advice that's been done through the National Coordinating Mechanism and in consultation with Safe Work Australia has taken all of that into account as well in terms of when rapid antigen tests should be used. So these are not simple questions and they require some thought for the answers.
Okay. Senator Davey, thank you. I've been very generous with the time, and we've only got the Minister until 4, so if we could just have answers be as succinct as possible, that would be appreciated. Can I go to Senator Lambie?
Yeah, thank you, Chair, very much. Good afternoon, Minister. Nice of you to show up. I'd like to remind you that you're required to be honest and truthful when you appear as a witness before this committee. You told us that you couldn't attend a hearing on the 14th of January. I don't even think you gave us 24 hours notice, but you can correct me if I'm wrong, Chair, because it would divert government resources from the COVID response. Was that just an excuse? Because quite frankly, to me, the other 530,000 Tasmanians down here give or take, it looks like you just won't come in because you would rather go to the cricket and drink frothies.
Well, Senator, I stand by the advice that I gave to the committee. I don't think it was as you portray it with respect to the notice. I think I came back to the committee relatively quickly in relation to the circumstance, and as I've indicated to Senator Gallagher earlier, and as the number of cases that were currently in the community and the circumstances that were occurring in aged care, the resources of the department in particular, but also the work that we were doing together in actually working the issues and looking to resolve the problems that were being faced by providers still stands. So I stand by the correspondence that I sent to the committee, and I've never refused to appear before the committee. The conversation that we were having was around the timing, and there's been some circumstances around that, as you might be aware. But I've not, on any occasion, refused to appear before this committee. I have a very, very strong perspective around the importance of process and respect for the Senate, the Parliament and its processes. I always have. And I was only too happy to work with the committee to organise an appropriate date, and I appreciate the consideration of the committee of the circumstances.
Would you be able to provide the committee the emails from the government resources that said that would be too difficult? Just before that, do you think you can provide those details to the committee? Those government resources that said this would be too difficult and we would not be able to show up. Can you provide that, Minister?
Well, Senator, I'll provide what advice that I have that was written. We did have a number of conversations with the department in relation to this, but as I've indicated to you, the work that we were doing on the morning of the 14th, in my view, the work that we were doing with COVID Shield, for example, to bring forward the vaccination, the booster shots in residential aged care was absolutely critical work. There's been criticism of the government for that process, but if you look at the timeline of the booster rollout program in residential aged care, can I say that the work that's been done by General Fruin and his team in COVID Shield has been quite significant because we've had to compress the vaccination program in residential aged care as the advice has changed
Thank you, Minister.
as the program's rolled out, and that's been essential work, Senator.
If you'd rather not apologise to people out there, that's fine. I'd like to move it on.
Well, Senator, you asked me about the work that was being done.
Hang on a sec, Senator Lambie. because we're doing this over a number of mediums, it does get very difficult if people are talking over the top of each other. So, Senator Colbeck, I think if you could keep your answers succinct, just because Senator Lambie only has a few minutes to answer questions, but Senator Lambie, it would be helpful if you don't talk over the Minister as well.
Okay. I finished that question, thank you. Minister, on December the 23rd last year, the Department of Health put out a statement promising to send rapid tests out to aged care homes in January. The statement said, and I quote, "The RAT kits being provided are to support, firstly, testing of aged care staff, including volunteers and subcontractors at each care service, and testing regular visitors on arrival at the service. This includes family and friends of residents, visiting allied health and other service providers. When the department put out that announcement, did they give you an estimate of how many tests they'd need to test staff and regular visitors at aged care homes?"
Can you give me the date again? Sorry, Senator, you cut out a little bit when the...
So that was December the 23rd last year. The department put out a statement.
I might ask Michael Lai to...
Michael Lai, Deputy Secretary, Ageing and Aged Care. Senator, the provision of RAT tests was based on modelling the department did, which took into account the size of the facility, number of residents, number of staff, and the regular visitor traffic is people who are typically regarded as, part of the staffing quotient. Then I know they're not staff; they're very much distinct from that, but. In many respects, those facilities take them into account. So that was our modelling.
I understand that. I just want to know one question. Did you give an estimate? Was there an estimate given? I don't want to hear the rigmarole. Right, so you had an estimate?
Yes.
Could you provide the committee with that estimate, please?
I'm happy to take that on notice, Senator, and give you the figures that we've modelled.
Unless you know how many tests that they did estimate that the aged care homes would need. Do you have that on?
I don't have it on me, Senator, but I don't have it on, but I'm happy to provide it to you.
Okay, and when you provide that to us, can you please tell us whether you secured every single one of those that you estimated?
Happy to, Senator.
Thank you. An updated announcement from the department on the 19th of January says, due to the high demand for rats, we are prioritising supply to outbreak and exposure sites. Have you failed to meet your commitment to test workers and regular visitors at each and every aged care service?
Senator, I might defer to Mr McBride.
Shakespeare, Deputy Secretary of Health Resourcing. We're currently providing out of the National Medical Stockpile 2.5 million rapid antigen tests to all aged care facilities for the purposes of both managing outbreaks and now surveillance as well. We prioritised...
When did you do that? Are you currently doing it now, or had you done it? Had you done it, right? Had you done it on the 23rd last year when you promised? Or are you just doing it now, 5 weeks later?
There have been changes in demand, particularly from facilities with outbreaks. At one stage, I think we were going through 3 million rats per week just for outbreak facilities. I don't think that would have been modelled back in December, but we've managed the rapid antigen stocks that we have to manage outbreak facilities. We are now back in the position where we can supply to all residential aged care facilities.
So a survey of aged care workers released yesterday says that 1 in 5 have had to buy their own rapid test. First of all, will they be reimbursed?
So we've provided 7.6 million rapid antigen tests to residential aged care facilities. I'm unaware of the survey that you're talking about and whether it's looked at those facilities that did receive rapid antigen tests or if they were surveyed in other facilities. We've provided a lot of rapid antigen tests.
So there's been no email, there's been no alert to individual people, not one of you, about 1 in 5 have had to buy their own tests. What I want to know be the case, and that is true, which I'm believing it is true, and I believe that you already know that, right? And I believe you've had emails to that extent and been told. Will you pay those people back their money? Will you reimburse them?
Senator Lamb, we're just having a change of witness here. This is the reason
Sorry,
for the
Senator.
delay. Yep.
Different areas.
Mr. Liesbach.
I'm not aware of the survey, but in any outbreak situation in a residential aged care facility, the provision of rapid antigen tests is one of the things that if a facility provides that themselves, or PPE or any other ancillaries to deal with that management of that outbreak, they can claim that expense back. So those, if a worker purchased a test in the course of that, they would be able to claim it back as an expense.
On what? An expense on what? Their tax?
No, they would. The program that we have in place means that the facility can provides after the outbreak to the government the cost of managing the outbreak, and all those expenses are paid for by the Commonwealth Government that have been incurred, including if an individual had to purchase a test.
Okay, so every one of those individuals will show their receipt and every one of them will get their money back. Can you tell me the turnaround time it will take to get their money back? Because these are some of the most poorly paid people in the workforce. They'd like to know.
So the way the grant works, Senator, is that the facility would lodge a claim with the Commonwealth, and the Commonwealth then make a payment back to the facility for all those costs incurred.
What? How long does the grant take? Sorry, this sounds like a very awkward scenario. How long does the grant take?
Well, it depends on the speed with which the facility puts the grant in. We assess it and we provide the money back.
Senator Lambie, I'm going to have to hand the call on in a sec. If you've got a final question.
So we don't know what the timeline is, there's no quick turnaround, and that the workers cannot put in their receipt immediately and get a back payment within at least 7 days.
Well, Senator, I would expect that the person could put their receipt into the facility and get their expenses paid, and the facility would well know that they can then claim to the Commonwealth for that cost, and that we will be good for it.
Okay, but workers can't put in the expense claim. We simply want to know what the turnaround time will be. Once again, they're lowest paid workers. They're going to take 2 months, 3 months? What's the turnaround time, mate? You must have an idea here.
So, Senator, it entirely depends on when the facility puts a claim in, and I'm happy to come back to you with what the average turnaround time is on these grants. But we are equally more than comfortable, if you provide an example, to go and talk with a facility to make sure, if there is an instance of a worker who is out of pocket, talk to the facility about reimbursing that person immediately in the knowledge that they can claim to the Commonwealth for the costs of the outbreak.
Well, maybe the Minister should go and visit them, mate, and he probably knows as much as what we do. That's my first thing. My last question is this. Unions and industry groups fear we're facing a mass exodus of workers from the aged care industry. How many staff have left the industry since the start of the Omicron outbreak, and are you monitoring that?
Senator, we're monitoring very closely the workforce, the situation with regard to workforce, and for that reason the government has announced in the last few days a bonus for the aged care workforce, and that is designed to go directly to people who are now entering the aged care sector, who we're trying to get people to enter the aged care sector, but most importantly, it's about trying to make sure that we retain the existing workforce in the aged care sector in the short run during this difficult time.
Firstly, how are you monitoring that with how many, you able to give me numbers that have left since you're monitoring that? So if you can provide that to the committee, that'd be fabulous. And seriously, tell me how you think $2 and I think about 6 cents a day is going to encourage people to stay or go into aged care. Seriously, when they're the most underpaid in Australia. Really?
Okay.
Who came up with that idea? Tell me who came up with that idea. Who came up with that idea to give them that amount of money? Where did that come from?
Senator, I'll take some of your question as comment, but what I can say is that the industry has indicated to us that the 3 times previously that we've used this mechanism, that it has been helpful in retaining staff.
Okay, I'm sure we'll have more questions on that throughout the hearing. Thank you, Senator Lambie. Senator Rice.
Thanks, Chair, and thanks, Minister, and the people that are there. Minister, there are at least 9,643 cases of COVID-19 amongst aged care residents and at least 14,257 amongst aged care workers. But you've just said in response to Senator Gallagher's questions that the system isn't in crisis. It's performing extremely well in extremely difficult circumstances, that infections are running in line with infections in the community, and that it's performing so much better than last year. Can you tell us how many people have died in residential aged care of COVID-19 so far this year?
Senator, I have acknowledged in all of my comments that there is genuine stress in the aged care sector. I don't characterise it as crisis, as some would like to do, but I have acknowledged the difficult circumstances, and but despite those difficult circumstances, we all ought to acknowledge how well providers, and particularly the workforce, are doing. So this year, according to the latest information that I have, 471 deaths in residential aged care amongst residents, off the back of 282 in 2021 and 685 in 2020.
So 471 people who have died in residential aged care in 1 month and 2 days, compared with 282 in all of last year. You still say that it's performing so much better than last year?
Well, Senator, the context that I put that in was in respect of the number of infections in residential aged care, they are the stats. They are the actual numbers that, in comparison to 2020, it is significantly better than it was in 2020. On respect of the number of infections, in proportion to the number of infections in the community, it's pretty much on a par with 2021. But that performance is so much better, and my view, and I think the statistics support that is due to a number of factors. That's the high vaccination rate. 90% of residents of residential aged care have been vaccinated. That has made a difference. The staff in residential aged care are at 99.9% vaccinated. That has made a difference. The improved infection control procedures in residential aged care has made a difference. The screening of staff and all visitors to residential aged care facilities has made a difference. And so I think it's genuinely responsible to acknowledge that. Is the sector doing it very, very difficult, having a really tough time at the moment? Are they under stress? Absolutely they are. There's no shying away from that, and at no point have I done it. But I think it's important to recognise that the sector is actually, despite all of those difficulties, demonstrating that they have worked to put in place measures in support of residents, the vaccination of the residents, the vaccination of the staff, the improved screening procedures, the better IPC, all of those things have had a positive impact. You would be concerned if they hadn't, Senator. And so I don't downplay the emails that Senator Gallagher read out from a worker who's working long shifts. I congratulate them for doing that. I thank them for doing that, and I acknowledge the work that they're doing. And I have to say, in respect of the question just asked by Senator Lambie, we had a meeting with aged care peaks and the unions a few weeks ago, and I was making the same acknowledgements of the work that the workforce were doing, the impact of the stress that they were under, given the circumstances. And one of the union representatives said to me, "We thank you for your acknowledgement, but we want something tangible." The tangible has materialised in the context of the support payment that was announced by the Prime Minister on Tuesday. In a similar way to the bonuses that were put into the sector in 2020.
We've got limited time, Minister. I don't want to talk over you, but I have got some other questions.
Well,
So,
Senator...
Minister, so are you essentially saying to the families, the loved ones, the carers of those 471 people who have died so far this year that there's nothing more that you could have done? Is your message that you've just been giving to us the same? Would you give that same message to the families and the loved ones of those 471 people, that the system's performing so much better than last year?
Senator, I know how difficult it is at a point in time when you lose a loved one. I think we all understand that. And so I'm not going to try and apply some platitudes to the families of those who have tragically lost a family member to COVID at any point in the pandemic. I send each and every one of those my heartfelt condolences and continue to work with the sector, with the providers, with my agency and my colleagues to do everything that we possibly can to support the sector in ensuring the best outcomes. We are in a situation right now where 99% of providers have had their booster visit. We're on the cusp of receiving new treatments, which will also make a difference in support of the residents. We continue to look to new measures all the time to improve the way that the system works, to support the system and provide them with the resources that they need in support of the residents. As Ms Shakespeare has said a moment ago, we're now in a situation where rapid antigen test supply is to the extent where we can supply every aged care facility in the country with rapid antigen tests, supporting those that have an outbreak and those that are requiring them for screening to mitigate the entrance of COVID-19.
Okay, I mean, I think we've got very different views about doing everything that you possibly could do to support the sector, and that, you know, the crisis that we are in means that hasn't been what's occurring over the last 12 months. But let's go to what that means for you, doing everything you can to support the sector. And you talk about the booster shots and rapid tests, and you just mentioned the bonuses that are going to be given, which is, you describe that as the tangible thing that was going to be done. So we've got two $400 payments as a bonus for workers. Minister, your salary, I understand, is over $332,000 a year, which is over $900 a day compared with that $800 that you're giving to aged care workers. That's the case, isn't it?
Senator, that would probably be about right.
So on the Friday the 14th that you went to the cricket, you earned more that day than the bonuses that you're paying aged care workers, didn't you?
That's the case for every day of the year, Senator, and that's the case for every day of the year, regardless of where I am and what I'm doing.
And so that's the tangible thing that you are doing.
Well,
Minister,
Senator,
instead of mucking around with one-off attempted election bribes to workers, why isn't, for example, at least on aged care salaries, why isn't the government being a party to the Fair Work Commission case and committing to support the increase in wages of aged care workers by 25%, instead of paying them less than what you earn in one day?
Senator, this is not the first of these bonuses, and as Mr Lai said to the committee a little while ago, the advice that we had from the sector was that they had a positive impact in relation to retention of workforce in the sector. We know that particularly in 2020 there was a significant reluctance of workers to go to work when there were COVID outbreaks, and there were people considering leaving the sector. We put in place a series of bonuses for the workforce at that point in time. I've indicated to you very clearly the conversation that I had with the unions. Minister Hunt was a part of that as well. That's why we're doing what we're doing. The Fair Work case is a process that is continuing appropriately. We're providing the appropriate level of support to that process, meeting the requests of Fair Work Australia as they consider the case. My view is that the sooner that case is resolved, the better for us all, so that we can then start applying the decision to the sector. I think it's important that we do that. I'd be concerned if there were any further delays, bearing in mind that it was supposed to initially was supposed to bring its decision down in November last year. It's been extended once. And I would sincerely hope, acknowledging the independence of Fair Work Australia, I don't want to cast anything there, but I think it's in everybody's interest that that decision is made appropriately. The government's view is that Fair Work Australia has been established to independently set wages, and we believe that that is their role. We respect that role and will provide the support that they request in respect of the current case.
Minister, given you know the critical importance of wages to aged care workers and we know the huge pressure they are under, do you personally support an increase of the 25%? That is a very reasonable increase to bring the wages of these critical workers up to something that's half reasonable.
Senator, I don't believe that politicians should be setting workforce wages in any sector of the economy, and that's why Fair Work Australia, previously the Industrial Commission, was put in place to do these things so that they can consider all of the relativities that are important in establishment of wages. I respect that process and I believe that they should be able to do that. It's not a politician's job to set workers in the wages in the workplace at any level, our own or anyone else's. And so I respect the process that exists and has been legislated by the Parliament.
Minister, how many of the 2,000... Yes, Chair, it's my last question.
Yeah.
Okay. How many... Oh, I've got a couple of... I'll ask them all at once.
Okay.
So how many of the 2,000 plus residential aged care facilities are currently experiencing staff shortages, and how many facilities have experienced extreme staffing shortages in the last 60 days, and how many of those have received surge workforce support from the Commonwealth?
Senator, I'll probably have to give... That's a fairly detailed question. I suspect that I'll have to get some specific advice on all of those particular matters and provide them to you on notice. But there's a significant number of facilities that have had outbreaks, some of them worse than others. Some of them have been only a staff member or a resident or a few staff members. But I'll have to take on notice the specific detail of that because it's a fairly complex set of information.
Okay. Well,
I'm happy to do that and provide that for the committee. Okay.
And on notice then, and how many aged care workers have left the sector in the last 60 days? How the government is tracking rates of resignation and job vacancies, and what comparative data you've got. And I suggest this is absolutely critical data that you should have your fingers on the pulse of. We're in the third year of a global pandemic.
Okay.
It's just extraordinary that you're not able to at least have some level of knowledge of this critical data here today. Thank you, Chair.
Okay, thank you, Senator Rice. Senator Patrick.
Thank you very much, Chair. I hope you can hear me.
Yep.
Thank you. My question, I'll start with Professor Skerritt, if I may. Just in relation to COVID-19, which is also known as Spikogen. My understanding is that has now got provisional accreditation by the TGA. Can you just tell me what that actually means, and then next steps associated with that particular protein vaccine?
John Skerritt, Head of TGA. I think there's some confusion. Spikogen, sorry, you're talking about the Novavax vaccine, is a protein-based vaccine.
The COVID-19,
Oh, sorry, no,
Professor-
okay. So it's got a provisional, so there's two protein vaccines that have been in the news lately. The first is the Novavax one, which has a provisional approval. The second one is the South Australian developed, Iranian trialled COVAX vaccine that I understand you're referring to. Now, it's got a provisional determination. So what that means is that for any provisional determination, it's when a company comes to us and says, this is a serious condition, we have promising early data, and that means that they are then eligible to apply for provisional approval. Now, we provided that determination a little while ago. We've met with the company. They have not yet put in a full submission, although we're expecting one soon. Once we receive their submission, we'll review it with the utmost urgency. One of the challenges, of course, is that their clinical trials have been conducted in Iran, and while we don't require clinical trials for any vaccine or medicine to be conducted here in Australia, obtaining information, for example, on the oversight of the clinical trials and so forth is a little bit more challenging with the Islamic Republic of Iran compared with some other countries, but we're working on that with the company.
Yeah, I think they were forced into that position by the Department of Health. I'll come back to that later, and that's not a criticism of you, Professor. So what's the likely time from their action to essentially TGA approval? I know how long's a piece of string question, but yes, typically how long does it take? Unfortunately it is, and it depends on the quality and completeness of a submission. So if you, for example, look at the Pfizer vaccine, that was approved in a matter of some weeks. On the other hand, the Novavax vaccine, where they moved their manufacturing facilities several times and essentially almost had to start again with validating their manufacturing process, that took many months. And so it will first of all depend what they apply for, what group of patients and so forth, and then secondly, what data they're able to provide to us. And so all I can say is that we've also accept data on what we call a rolling basis. So they can give us data on the manufacturing, and they can give us data on the clinical trials at a later stage. They can give us data on the quality tests at a later stage. So we will work with them to have the most speedy review possible, but obviously the review has to be complete so that we're convinced of the safety, quality and efficacy of the product. So again, what would be the minimum time frame? What would you expect as a... The minimum time from receipt of a complete application could be a matter of 6 or so weeks. We do go to an external committee. But I do need to emphasise that's on the basis of receipt of a complete application. We're also well aware that this is a small company that is essentially a couple of people providing most of the data and so forth, whereas a typical vaccine submission probably has several dozen, if not 100 staff working on it from one of the big pharma companies. And so a lot will also be dependent on the company's ability to come back to us to answer our questions. With a rolling submission, it's a bit like a conversation. You get some material, you ask questions, the company responds. And so a lot will depend on how quickly they can get back with their responses. Okay, and can you confirm, I think you just said it, that the vaccine they've currently got, which is approved in Iran, is manufactured in Iran? It's manufactured in Iran by a company called Synergen. And again, the challenge will be getting information on the manufacturing processes. So, for example, even though, of course, international travel has been difficult under COVID, when we have a vaccine manufactured in the US or in Germany or in the UK, we're able to go to the British regulator, which is one of the international group of regulators, and say, can you basically give all your records? Or if there's something we want to check on, can you visit there with a GoPro and show us the equipment? The Iranian regulator is not a member of the global group of regulators, and so there will be some challenges there. Okay, thank you. That's my question to the TGA, but I'll now come back to the Department of Health and the Minister. What Professor Skerritt said is correct in that that's 19, a very small company, but would you agree that actually one of the jobs of government is to help the small companies become larger companies? see Australian companies being, and that sometimes requires a little bit of help from government.
Well, Senator, obviously this local company is doing some significant work. They've put in place a number of processes to develop their product. As Professor Skerritt has indicated, the TGA is working cooperatively with them in a rolling process to support that rather than having a stringent apply, reject or approve process. And so I think in that sense, the work that the TGA is doing with the company is actually supporting him in that way. It's actually supporting the development of their product by going through a rolling process.
To be clear, my criticism is not of the TGA. I understand they have actually been very helpful. But if we go back to the history of what happened here, was that the Adelaide company applied for a grant back in April 2020. Unfortunately, the grant went to University of Queensland. In total, no one's been able to see anything relating to that grant application. That whole MRFF is a corruption incubator. Of course, UQ failed. Unsurprisingly, the Adelaide company has been developing and delivering vaccines internationally. UQ had never done a vaccine in the past. So we end up with a situation where the Australian company had to go to Iran to get approvals or to do their phase 2 and phase 3 clinical trials. So they've done that now, and we've just heard the extra burden that will create on this company as it seeks TGA approval. My next problem, or the understanding of the next problem, if they get approval, there's difficulty in terms of manufacturing, again, because of the small size. And I'm interested in noting the failure of the department to in any way assist this company, what they will do to make sure that this vaccine can get manufactured in Australia. And that may involve putting a little bit of pressure on companies like CSL, or even just assisting the company. And I'm asking what the department will do to assist them finding a manufacturing home here in Australia for the South Australian vaccine.
Senator, I just might start by my understanding is that the company did receive some funding from government. I think the grant was $1 million. So they haven't been completely unsupported, and I might throw to Dr. Murphy to elaborate on that.
So, Senator, in the medical research commercialisation initiative, which was the COVID-19 round 3 grant opportunity, they received $1 million as part of that, along with some people developing mRNA vaccines. It is, I mean, if you've referred to the UQ company, but they really had a very strong partnership with CSL, and we would expect a company that had a promising vaccine to.
Oh, we've lost everybody, haven't we? Oh, no,
yeah. So the UQ.
Come back. Sorry, I missed that.
Yeah, sure. So they certainly, as you have acknowledged, they did apply for earlier competitive MRFF grant processes, and they weren't successful on the basis of the independent peer review, and that was an independent process. And I know we've discussed at great length your concerns.
A secret independent process, yes.
Yes.
We now go back and look at that process.
Okay, Senator Patrick. Senator Patrick, can I just stop? Professor Murphy, you've not finished. Can he just finish his answer? It's impossible when you talk over the top of each other.
Sure.
Yeah.
So they did not, at their science, as the assessment at the process was that their vaccine or their process was not as far advanced as others, but later on in the further grant process, as we've identified, they did get $1 million. I think the issue with UQ is that they had very promising phase 1 trial data, and they formed a strong partnership with CSL. That was not a government did not bring them together. Government did not say to them, you must work together to manufacture the UQ vaccine. UQ and CSL got together and they said, you have an exciting vaccine, we will develop it, and then they came to government with a proposal. So I do understand the frustration of Professor Petrovsky, but these MRF processes, we do defend their independence.
Okay, Senator Patrick, you don't have much longer, so...
Okay.
Yeah.
I'll just point out, I mean, that they are done in complete secrecy. Surely the Department of Health can now look back and say the wrong choice was made. And actually that should have been apparent from the lack of experience that UQ had in all of this. So I'd like a commitment that you go back and have a look at how the Department of Health or MRF got this so wrong. And secondly, noting the amount of money we've thrown at CSL to assist in terms of things like having AstraZeneca manufactured here, is the government willing to assist an Australian company have manufacturing done here in Australia for both Australia and the world? And that might be a question for the Minister.
Yeah, thanks. Well, Senator, it is a different portfolio, and so my comments will be pretty generic in that sense, but the government has announced a strategy to promote the development of appropriate technologies in Australia through the industry portfolio is my recollection. And so we are actively looking to do those things. We have made investments, as has been discussed by PM&C today, in relation to mRNA manufacturing. There's some work that's being done with a number of advanced manufacturing businesses around the country to promote sovereign capacity, and we'll continue to look at that. And those options remain open to businesses such as this one, and I'm sure that the appropriate minister would be prepared to receive representation through the processes that support those grant programs.
Okay.
Okay, thank you, Minister. And look, sure, and maybe this is a case of, Minister, if you'd undertake to help me offline, making sure that I can connect to the right players inside government to give support to a sovereign company with a fantastic background that has actually been fettered by the department to date in terms of being able to advance what has now become, looks like it's about to become a very successful vaccine.
Okay. Is that it? No
So, Senator, I'm happy to engage with you. Okay. I'm sure other of my colleagues would too.
Thank you.
Okay.
Thank you, Chair.
Thank you, Senator Patrick. Senator Henderson.
Thank you very much, Chair. Look, I firstly just want to perhaps raise this with General Fruin. I'm just wanting to understand all of the Commonwealth support provided to aged care facilities since the start of the pandemic, including the 100 million PPE units, including 7.6 million RAT tests, and including all the other items.
Sounds like you know them, Senator Henderson.
Well, I haven't got the comprehensive list. I've got a good insight.
Okay.
There. Thank you.
They stand ready.
But I would ask,
they stand ready to assist.
Major General Fruin. Sorry, Chair. I would just ask Major General Fruin if he could just provide that information.
I think more
General Fruin has handed the baton to Mr. Lai for that.
More appropriately to Mr. Lai.
So,
thank you, Mr. Lai.
So, Senator, I'll try and cycle through the different bits. In terms of rapid antigen tests, I think Ms. Shakespeare mentioned that I think the current number of deployments in aged care are 7.6 million. In terms of PPE, the National Medical Stockpile has provided residential aged care facilities with 34.7 million masks, 14.1 million gowns, 40.1 million gloves, 11.6 million goggles and face shields, 130,000 bottles of hand sanitizer. There's been a large investment across a range of programs into support residential aged care facilities in outbreak settings, I'm happy to provide on notice, but I think the total investment's around $2.1 billion, and most recently around $210 million for the what is the fourth instalment of an aged care worker retention payment, the $800 payment, which is being made in 2 instalments. I think the other thing...
Mr. Lloyd, what's the total amount of aged care worker bonuses being paid since the outbreak of the pandemic?
Well, there's been 4 iterations, and each one has been worth up to $800. It's prorated based on the number of hours a person works and the setting in which they work. And so, you know, there'll be some workers who will have benefited from all of those payments, and there'll be some who've benefited from some of those payments. And in relation to the latest retention payment, our aim is to recruit some new workers to the sector, and if they're working in the sector on the census date, then they will benefit from the payment as well.
And also the Commonwealth has been providing support for surge workforce, is that right?
That's right. We have 2 principal mechanisms. We have a grant program, which I mentioned earlier, which reimburses facilities who experience an outbreak, and so that covers the costs of major expenses like if they have PPE expenses or waste expenses or workforce expenses. We have $147 million for our workforce surge program, and that gives facilities access to workforce from a range of agencies that we have engaged to support them.
Can I just ask, moving on to another question in relation to rapid antigen testing, what's the total number of rapid antigen tests that are being produced or assembled in Australia at the moment?
John Skerritt, Head of TGA. Senator, there's only one rapid antigen test that is actually being assembled in Australia at the moment. There's no tests being produced end-to-end in Australia.
And what about the number of tests which have now been approved by the TGA, Mr Skerritt?
So TGA has approved 23 self-tests and 43 point-of-care tests. These are ones that can be done under supervision, for example, in industry or by healthcare professionals or whatever. And I commented not long ago, but last time I looked, a couple of weeks ago, we'd actually approved more self-tests from the US FDA, despite my envy of their significantly higher staffing and reviewer resources.
I'll take that as a comment, Mr Skerritt. Just in relation to, there was some concern about rapid antigen tests which were being produced here but exported to the United States that weren't approved by the TGA. Can you just reinforce the importance of TGA?
So
and why that is so necessary in the case of rapid antigen tests?
Well, the importance is, of course, that the tests work reliably. So I talked earlier about the fact that now a well-performing rapid antigen test is a central part of our armoury when we have a high amount of endemic COVID disease. But you can imagine a test that either doesn't pick up COVID when you are significantly infected, has significant impacts. If you then take a negative test and you enter an aged care facility or go to a social event with family and friends and you become a super spreader. The other hand is if a test gives a false positive result and you're a critical worker or you also unnecessarily isolate or unnecessarily concern close members of family and friends. So knowing that tests provide the right results, that they also are easy to use and easy to interpret and suitable for people who don't have a medical training to use, that you have a number to call if you have any questions or issues about it, and also in our Australian summer climate, that the tests will work even if you leave them in your car and so forth. We're not advocating when people are putting them on a hot dashboard, but you need the tests to be stable, that they don't break down after a matter of a few weeks.
And how many are pending?
Well, we had a small tsunami of people put submissions to us just in the last couple of days. So I'll get the figure. As I said, it was literally a small tsunami. The issue, as I've said all along, is not so much that we have a big backlog of people waiting to have their tests reviewed. The trouble has been that, for example, the 7 critical performance requirements for the tests, I've talked about some of them, the fact that you don't want to get a test to give a positive result with a common cold, for example, when it's COVID, and so on. So what the real problem we're having is that companies, and many of these companies do not have a background in medical products. They may be in clothing, they may be in building supplies, and they've seen a commercial opportunity, and that's fine, but it's a different game selling men's socks and selling COVID rapid antigen tests as far as the consequences. So in the last few days, we've had several dozen applications. We've got 68 ones that we are currently looking at to see whether the applications are complete. However, just to put that in context, we've got 93 where we may have had 1, 2 or 3 out of the 7 critical performance requirements as far as data. And we've gone back and saying, you've left out number 4, 5, 6 and 7. We need that before we can proceed. So we have had a small tsunami. A week ago, it was something like 15 or so. That's good. Obviously, people are seeing a big commercial and demand opportunity for rapid tests. But I would venture to say that in a country the size of the US, where they've actually approved, at least last time I looked, fewer tests than we have, it's not necessarily the variety of tests. There's quite a large number of different products available on the market. But we have no limit on the number of products, and if we are able to approve another 20 in the coming weeks, that would be fantastic.
All right, look, I just want to go ask the Department of Health in relation to the stress on the testing which emerged in December and early January. Not sure who the best person is to direct that question to. I'm keen to understand in more detail the decision of states, particularly Queensland, which required holidaymakers with no symptoms to obtain a PCR test before the state. What sort of pressure did that place on testing capacity, particularly in Victoria and New South Wales?
Okay, and that has to be your final question, Senator Henderson. So I'll go to Professor Kelly now.
Thanks, Senator, and thanks for your question, Senator. Considerable, I think, is the short answer to that. I remember at the time, in the lead up to a couple of weeks before Christmas, in our extremely regular, pretty much daily AHPPC meetings at the time, that the estimates of between 10 and 25% of all PCR tests being done in Victoria and New South Wales and the ACT, even higher in the ACT, in fact, were due to the requirements of other jurisdictions for their cross-border measures. I would stress it wasn't only Queensland, but a substantial amount of that was related to travel to Queensland.
And Professor, just a quick follow-up. Was Queensland's decision to impose PCR testing on holidaymakers without any symptoms, was that based on health advice?
That would have to be a question to the Queensland Government in terms of their own health advice. It was not a decision made at the AHPPC nor from the Chief Medical Officer of Australia.
Okay,
but
thank you.
Of any health advice which supported that decision?
So I think that's really a question for the Queensland Government, Senator.
Okay,
thank you very much. Thank you, Chair.
Thank you, Senator Henderson. Okay, Minister, how many aged care residents ended up being completing the 2-shot initial vaccination process? I can't remember just the percentage figure. How high did that go?
So in residents, 91.1% received the first dose, and the latest data says 89% received 2 doses.
Okay. And so how many of those have received their booster?
So as a percentage of residents,
Yeah.
so that's the overall percentage of residents, not a percentage of the 89.
No. Well, I presume it's the same group. If they're getting their booster, they would have had 2 shots, right?
The population of the aged care facilities does move.
The population
through.
of the aged
Sure.
care facility does move.
But you're only eligible for a booster if you've had 2 shots,
you've had
I
2
presume.
shots.
Yeah.
And so the current percentage, and there is a bit of a lag in the data, is 66% of residents in those 99% of facilities that have received a visit have had a booster shot.
Okay, so we're at 2/3 of the overall residential aged care population who have had their booster. What's the difference if you've been to 99% of facilities? Why is only 2/3?
Senator, can I say that is the $64 million question? So the anecdotal information that we've received back from the sector as well is about 80% of the 90% are taking up the opportunity for a booster. There are many reasons for that. We've discussed this with the sector. Some providers have gone to significant effort to convince their residents to take up both vaccination in the first case but also boosters. The Quality Commissioner and I wrote to all providers on the 18th of January asking them to provide encouragement to residents to take up vaccination and boosters. There's still some residents who have, despite having had the opportunity to be vaccinated for the first time during the booster program, not taken up vaccination. And there's not a specific answer to your question, unfortunately. There are very many reasons. I'll recount to you what occurred with the one provider who went to significant lengths where they put together a group of clinical specialist nurses who had a clinical conversation with the resident or the family of residents across their many facilities, and that process resulted in 50% of those who had decided initially not to take up a vaccine, or 51% to take up a vaccine. So many providers are doing significant work to encourage, but there isn't that I can give you a specific answer as to why people are not taking it up. If you look at the broader population of those over 65, we're 99% vaccinated.
Yeah. So is there when we say there's 99% visits, are those visits able to complete the vaccination in that visit, or is some of this caught up in the sense that they've been visited but you haven't been able to do all of the people who were eligible for boosters and wanting to be boosted? Is there a component of that in this?
So Lieutenant General John Fruin, Coordinator General National COVID Vaccine Task Force. Chair, with the visits that go in predominantly have been done by vaccine providers that we have brought on.
Yep.
In some cases, the facilities have done the vaccinations themselves. In others, it's been done by GPs and pharmacists, for example. Typically in the visits, there is the capacity to do the entire facility and including the workers who are in the facility, but there are a range of things that come into play in every facility. The Minister has touched on some. There is about a 25% turnover in these facilities every year, so some of the residents who've just come into the facility have only just completed their primary course and are not eligible for boosters yet, so there's some numbers that aren't able to sort of take it up. There is consent issues. Sometimes it is the residents themselves who don't wish to give consent. Sometimes there is a carer who has reasons for not wishing to give consent. So consent is a very significant factor in some of the take-up. There is also variability across not only facilities but across states, and some of that has been around those the local experience with COVID. We commenced the vaccine booster program in aged care facilities before Omicron really took hold. So in some areas where there hadn't been COVID outbreaks and Omicron hadn't yet hit, there was, of course, less of a sense of urgency.
So I'm trying to understand, is a visit tick done, even if some people haven't been done in that visit? That's the question I'm asking.
Absolutely, that's first visit, Chair, and we are already planning and have commenced second booster visits to try and pick up people who, for whatever reason, weren't able to get the booster the first time.
So that will happen, because I've heard people saying that if you didn't get it on the first visit, you're not coming back.
No, and I said in my opening statement, we're already planning the second visit.
All right. So I think, Minister, you said the figure of 471 residents had passed away this year from COVID in residential aged care. I don't know if that must be the most up-to-date figure that you have, is it? Yeah. Okay. How many of those residents hadn't received their booster?
Senator, to get that detailed information, which we would need to get from the states, so the information that we're reporting to you is the information that's reported into our federal system through our contact with the providers. I'll have to take that on notice so that I can give it to you, because there is a time lag in receiving that data from the states,
but it's pretty,
which gives that detail, that level of detail.
I would have thought that was pretty important information, though, from your point of view in understanding
it is, Senator,
the priority that is boosters, you don't know. Does anyone have that?
To get confirmed data, there is a lag in the actual confirmation of the cause of death from COVID with COVID, and also with that some of the personal details that come with it.
Okay, so are you telling me that the Commonwealth doesn't have that information, at your fingertips?
I'm just saying to you that there is a time lag
in
receiving that data from the states, because sometimes it takes a while. We've had a couple of circumstances in recent weeks where there's been a significant number of increases in the number of deaths reported in residential aged care. That has been a catch-up of information from previous circumstances, and in fact in the first couple of weeks of this month, of this year, we've had increases in the number of deaths reported in 2021 as well. So there is a lag in some of this information.
I understand that. Do you have any information about that? Do you have any that you have in the possession of the Commonwealth of people who have died since Omicron who were not boosted? It would seem to me a fundamental piece of information that the Commonwealth should understand.
So, Senator, we are anxious to assemble data around the circumstances of people's death, including information about whether they are people who are palliating or not, who were palliating, whether they were...
That's not what I asked, though.
I know, I understand what you're saying, what their immunisation status was. But as the Minister's saying, that data necessarily lags, and so it's not something that we can collect on a daily basis or a weekly basis. We are reliant on information from state and territory governments to assemble that. So we are anxious to receive it.
Have you asked for it?
Well, we work very closely with the states around making sure that we verify the data that we collect through our case managers who are working with facilities, and then the information that they collect and verify as we go along.
But have you asked for it? I've heard the Health Minister and the Prime Minister use this. Of this number who've died, so many were palliating, so they seem to get that information pretty quickly. I'm asking the same question, but would be fundamental, I would believe, to managing Omicron, considering the information I've picked up from all of you good people is that the third booster is necessary to protect from Omicron. And if a lot of people are dying without the booster, surely that would then have consequences for your approach in aged care.
So, Senator, you're right. Some of the information, though, is information that we collect through our systems through our case managers, and so the status in terms of whether a person's palliating or not is information that we can readily collect via Commonwealth channels with the providers. The other information that you're seeking, and that we obviously are seeking as well, because it informs what we do, we are reliant on an interaction with the states and territories, and so that's information that lags in terms of time.
Okay, well, I saw some of the states in there raising concerns around the numbers of aged care and the numbers of people that are dying without being boosted. So someone has the information, but you're telling me the Commonwealth doesn't, and you can't tell me whether you've asked for it either.
Well, so Senator, we have spoken to one of the jurisdictions where the information was released, and that material wasn't available to the people who we deal with in the department.
Sorry, what happened there?
That information wasn't readily available from people in the department, so I'm not sure how that information was assembled.
Right.
We can give you some historical information going back around vaccination status, but it doesn't answer the question that you're asking around boosters.
So at the moment, the best knowledge that you have in sort of preparing people in residential aged care to be protected from Omicron is that 66% of residents of aged care are boosted.
That's the latest data that we have, Senator, yes.
Have you formally asked the states and territories for that information? Have you?
Professor Kelly might address.
Senator, I've certainly asked.
You've asked somebody?
I have seen the reports that you've seen in recent days, where I think it was in Queensland, for example, there was a report that there were 10 deaths, 8 of whom were reported not to have been boosted. I was concerned about that. I've asked to get some detail of that information, and clearly it is important information that we want to get, but as I've indicated to you, having had that conversation with our officials, there is some lag in the data. So your question, legitimate question, of 471, how many? I can't answer that question in that level of detail, given the lag in the data.
Professor Kelly, do you have something to add to?
I do, Senator. So I can confirm the specific answer to your specific question. Yes, at every AHPPC meeting I discuss the lack of sharing of that sort of data with the Commonwealth from the states. It's been brought up in several national cabinet meetings as well. The challenge we have is that sort of level of detailed data is held by the states. It is, for privacy reasons, not given in an identified data set to the Commonwealth in terms of infectious diseases data. So it is not possible for me to link, for example, with the immunisation data, which would be the ideal way of doing this quickly. It is, though, available to the states to do that. They are incredibly busy, as you can imagine, at the moment with all sorts of other matters they're dealing with in terms of the data. But it is true, we do not have data, and I'm talking about death data in general, not necessarily specifically in relation to aged care. So we receive very timely information about the fact that a person has COVID, their age, their sex, their state of residence, but nothing more detailed than that. And lately, many of the other fields that should be filled out are not being filled out in a timely fashion by many states. So I cannot, at this point, give detailed and accurate information to the Committee on Deaths. But that is not an unusual thing. That's why we have the ABS vital statistics and the AIHW that do these with a couple of months delay, because some of these things, the crucial components, is it actually due to COVID, the death? What sort of chronic diseases and other things may be existent which have contributed to that death? Okay. Vaccination status, and indeed residence all come through. But the latest information I have in that sort of detail and accuracy is only up to and including the 31st of October last year.
So it's a real national plan working in action then. Well, I mean, it's just, I don't know, it's unbelievable really that some of this hasn't been worked through and worked out if National Cabinet had been working or functioning properly. Minister...
As Professor Kelly has indicated, there is a process to collect it. And it is important data.
But people are dying now. Like, this is the thing. You regulate and fund aged care.
If the states aren't reporting to us, Professor Kelly raises it at each AHPPC meeting requesting the information to be provided, and the states don't report it to us. It becomes very difficult for us to provide the information.
Leadership, where you're the Commonwealth Government, for God's sake.
Senator, we request the information. Births, deaths and marriages and the data relating to that are held by the states. There is a process for us to collect it and receive it. If the states aren't providing that information to us despite repeated requests, we continue to make the requests and we urge them to appropriately provide us the data, because I agree with you, Senator. It is important information, and it's important information for us all in our decision making, and it's important information for us to be able to report appropriately to the community. So,
but why aren't you and the Prime Minister beating your chest on it then? Like, you know, honestly, this is
Senator,
your area of responsibility in aged care, and you've got one hand tied behind your back because you don't get the information you need.
We have a process in place to collect the data. There's repeated requests for the data through the AHPPC. I'm very happy to reconfirm that request, that the states appropriately report the data through the appropriate processes to us so that it can be provided as it needs to be and used as a tool in supporting the sector.
Senator, can I just, you did ask a question about the protection given by the three-dose course or the booster. So our understanding is that is 98.2% effective in protecting against severe disease, and that includes in elderly residents in aged care.
If you have the booster.
If you've had the booster, yes.
If you've had the booster.
So I absolutely agree with your point. We would like to know more about the deaths that are announced every day by our colleagues in the States. But in reality, our main issue here is to protect people in aged care, and the best way we can do that is rolling out the booster program.
Agree.
Which we've already done.
Agree.
And Senator, a point that needs to be reinforced here is that the booster program has been significantly accelerated based on the changing advice of ATAGI in relation to the sequencing of the boosters.
Yeah, sure.
So we start. Well,
you
can dismiss it,
I'm
Senator.
not dismissing it.
You can dismiss it, Senator.
No,
but we started.
You misread my comment. I said sure. I meant to say yes. I agree.
We started on the 8th of November with boosters into residential aged care through InReach. On the 12th of December, we received advice that shortened the period between second dose and third dose. On Christmas Eve, we received further advice that shortened that even further. And can I say that I think that Lieutenant General Fruin and his team in the Vaccine Task Force have done a magnificent job to bring forward all of those facilities that hadn't been scheduled or vaccinated to get them completed pretty much by now. They've done a magnificent job because the circumstances have changed. The government, through Lieutenant General Fruin and his team, have reacted to that to bring forward significantly the visitation of booster shots into residential aged care, and as you've already been told, we're about to commence another round to ensure that those that didn't have the opportunity in the first round can take that up, because we understand its importance.
Yeah, but so say you've got 66% boosted, how many, in real humans, how many people are living in residential aged care now, currently, not boosted?
Well, the total population is somewhere in the vicinity of 190,000, so it would be that 34% of the 190,000 that aren't boosted, some of them by choice, some of them by virtue of the fact that when the booster clinic came through, they hadn't reached the eligibility period, or any of the other many reasons that we discussed earlier as to why people hadn't taken up the boosters. And as I indicated to you, the anecdotal evidence that I've received back from my discussions with providers is that about 80% of the 89, 90% taking up the opportunity. We have urged, myself, Quality Commissioner and all of my conversations with providers in the sector is to encourage people to take up a booster because all of the evidence demonstrates that it makes a positive difference.
So that's about, roughly about 60,000 Australians living in residential aged care who have currently not had a booster shot?
For a variety of reasons. And that's why we're going around again, Senator, because we know the value of this.
Minister, we've gone over time. My final two questions is, has the Prime Minister counselled you over your performance as aged care minister?
I wouldn't say I've been counselled, no.
Have you ever offered your resignation to the Prime Minister?
No.
Okay. Thank you. Thank you for attending today. We'll suspend briefly till 4:15, I think, is the program, and then we'll come back just with officials for the final session. So if colleagues could please advise me if you have questions. Thank you. The committee will now resume its hearing into the COVID-19 pandemic and the Australian Government's response. I will hand the call to Senator Steele-John. You have officials ready here for you, Senator Steele-John.
Thank you, Chair. Appreciate it. So I'll just start off by just trying to establish some shared understandings. Would an official at the table give me the Commonwealth's definition of a COVID death?
I think, Senator, I think it is actually quite an important issue in Australia. If somebody dies and at the same time they have a contemporaneous positive COVID test, their death is called a COVID death. So the COVID deaths that are reported in Australia include deaths due to COVID-19, where clearly the infection has caused or significantly contributed to the death, but also there are a number of people, and I think there's been some debate recently about in aged care, who have died with COVID, so where the COVID probably has been incidental, asymptomatic and mild. So, for example, we do know that there are a number of palliative residents of residential aged care who are being palliated at end of life, so they may have advanced dementia or terminal cancer, and they are being palliated, looked after with really high quality, compassionate palliative care, and they happen to have picked up the COVID virus. It hasn't caused any impact on their health, because we know that the great majority now of vaccinated people who get Omicron, even in the elderly, most of them are asymptomatic. So these people will still be recorded as a COVID death, even though there would be no plausible pathological basis for the virus to have caused or significantly contributed to those deaths. In some other parts of the world, they do make a distinction of deaths due to COVID and deaths with COVID. In Australia, because we've had such a low death rate, generally we report every person who dies who has had a positive COVID test at the time of their death as a COVID death.
And could I ask a follow-on to that? In the Commonwealth view, and in relation to record keeping here, that distinction there between dying with COVID and dying from COVID, is that a distinction that's made by the relevant treating practitioner? And does that distinction, if it's made, have a flow-on impact to how the data is recorded and produced by the Commonwealth?
It doesn't impact the data. As I said, Senator, the data is reported as if all deaths are COVID deaths. But as Professor Kelly said, as we analyse the death data through our complex AHW and ABS systems over coming months, I am sure that we will get a more granularity on that, and we will find that you know, if someone, for example, who is, you know, as I said, had terminal cancer, picked up an asymptomatic COVID infection, probably declined a booster because they had terminal cancer, and at the moment they are still reported as a COVID death. But we would hope, as we get better and better data, and we get all that data from the states, we get the comorbidity data, we get what's happened, the best insight we have to this statistic at the moment is that fact that, as Michael Lai said, we do know that some of the residential aged care providers have reported that, or they report to us, that 60% of the people who have died are in palliative care, and that would suggest that many of them, if not most, have died with COVID, not from COVID.
And are you able, in the data that you gather from the states, just specifically on that question of palliative care, are you able to identify duration of time in palliative care, so that the beginning, the middle, of the end of that period of time?
Not on the data we have at the moment. There will be, I think, some considerable statistical analysis that the Institute of Health and Welfare and the ABS will do on the COVID statistics over coming months. But at the moment, the only information we have is from the residential aged care providers, who say that these residents were receiving palliative care at the time of their death. We don't know for how long, and we don't know for sure whether they died with COVID or of COVID, but we assume that many of them died with COVID and had another cause for their death.
Okay, and can I, on the reverse of that question, the definition used by the Commonwealth of a COVID recovery?
Professor Kelly could probably...
Yes, so we do report on active cases. That would be people within 14 days of having had a COVID test proved positive.
Right.
So those that are not active and have not died are recovered by that definition.
Okay.
Yeah.
Yeah, not active, not died, recovered. Okay. Now, the New South Wales Department, in a recent press conference, their Chief Medical Officer, Professor Chant, made reference to individuals on a pre-palliative pathway. And I'm wondering whether there's anyone at the table there. Is that a terminology that the Commonwealth is familiar with? Has New South Wales explained to you what they mean by that?
Not to my knowledge, Senator. It's not a concept that I'm familiar with. You know, palliative care is a pretty well-defined clinical circumstance, and it's now fortunately a very well-developed and positive specialty. And again, in aged care and in other parts of the health system, palliative care is a very positive and affirming and caring set. But I'm not sure what a pre-palliative pathway is. I'm sure Professor Kelly could ask Dr. Chant what she meant. He talks to her about every day.
Yeah, I will. I haven't got anything else to add to the Secretary.
Okay.
That'd be useful. Thank you. Simply because, in many ways, like with a pre-palliative pathway from a certain point of view, that would be good to get that shared understanding. Can I ask you how many to date? How many NDIS participants have died, either from or while having COVID-19?
Professor Kelly will get that, but again, the data will include both with and from COVID, because, as I said, we report all COVID positive deaths as if they were COVID deaths.
So just give me a moment, Senator. So in terms of, through the whole pandemic, and this is up to the 31st of the 1st, and this is data from the NDIS Quality and Safety Commission, so these are NDIS participants, 51 have passed away.
51. And do you have the similar figure for those that were DSP, disability support pension recipients?
I don't have data on that, Senator. I'll have to take it on notice.
All right. Do you think that you will have data on that? Because I know that's the two data sets of disabled people that the Commonwealth collects.
That data would have to be sourced from DSS, I would think. Sorry?
I think we'd need to look into matching the death data we have with the data held on DSP recipients by the Department of Social Services, so we can look into whether or not that can be made available.
So you haven't, just to clarify, that hasn't already been done, to your knowledge?
To my knowledge, no.
Not to my knowledge, Senator, no, but we can take that on notice and see if we can get that from the department.
Yes, please do, because okay, yes, please do. It's a very important set and another one that I would have hoped that we'd have 2 years in. Can I ask you what is your understanding of the current percentage of the Australian population that has it's defined as having an underlying health condition?
Do you mean in relation to deaths?
Yeah. We're having a little bit of an issue with your audio, Senator Steele, John, where we're kind of occasionally would clip a word and we don't hear it. So could you just repeat that? No, that's fine. It's happened this afternoon.
So just in relation, my understanding is that if you look at the population as a whole, about 43% of the Australian population can be counted as having an underlying health condition, matching the definition that is used by the federal department in relation to the reporting of COVID deaths. So I just want to check that that's correct, and B, that's up to date figure.
So I'm not sure I completely understand your question, Senator, but I will give you an answer, but please apologise if it's not the answer you're looking for. But again, as I mentioned earlier, and the Secretary also mentioned, we do have, it is actually a legal responsibility of medical practitioners to provide a death certificate, including underlying causes of death for every single death in Australia, unless they are unable to do so, in which case it becomes a case for the coroner to examine. And so that more detailed data that we talked about that goes to the Australian Bureau of Statistics and then is provided to the Australian Institute of Health and Welfare looks into these more detailed matters that you're referring to. We know from the last, and so this is back again to all deaths in COVID-19 up to and including the 31st of October, so it's not timely, but it is complete. 71.2% of people had a pre-existing chronic condition certified on their death certificate. So almost 3/4 of people that died up until that point did have a chronic disease as defined. In terms of what proportion of the Australian population has one of those chronic diseases, I think you'd be in the right sort of ballpark, but I'd have to take that on notice for in
All
general.
Right, and I think maybe I missed a couple of words there, but I think you've just given me actually broadly what I was looking for. So of the death figures that we have to this point, did you say 33.5% had an underlying health condition?
71.2%.
71.2%. And can you give me an idea of what constitutes an underlying health condition under that? Are we talking people with cancer, or are we talking people with serious respiratory conditions?
There's a range of conditions there, Senator, but I'd have to take the full list on notice. What I can say is the most common comorbidity was diabetes, and the second most common was obesity, and heart disease and lung disease, chronic lung disease, were also high on the list of underlying causes in that group. So that was the first 1,600 and just over 1,600 deaths in the pandemic to that date.
Okay.
Senator Steele, John, I'm going to have to hand the call in a minute, so if you can just finish up this line, I'll try and come back to you before 5:30.
Thank you. I appreciate that. Just to clarify one of your answers earlier in relation to the data set that we have in relation to NDIS deaths of NDIS participants, you've told us, I think, that data comes from the Quality and Safeguards Commission. Was that correct? That's the entity you mentioned?
Correct.
So that would mean, though, wouldn't it, that those are actually only figures of disabled people who died with COVID, who at the time of their death were receiving a support provided by a registered NDIS provider, because non-registered NDIS providers don't have to report figures to the Commission, do they?
That's correct, Senator. So there may be a slight underestimate, but that's the data that's come from that source, which I would say is complete.
I think there's a potential for a significant underestimate there, given the number of unregistered providers. Am I right in saying that 2 years in, the Commonwealth still does not have an accurate picture or hasn't even begun collecting data to answer the question of how many disabled people, separate from NDIS participants, how many disabled Australians have died from COVID-19? Can you answer that question?
So, Senator, I'm just reporting to you the information I have from the Department of Social Services, who I know do have other data, and so, but the NDIS participant data, as I've supplied to you, is the one that we're following in relation to that matter.
But do you have? But you're sorry, Chair. Just one addition.
Yep.
You're the Federal Department of Health. As you know, I'm asking you. You can give us how many Australians have died to your knowledge of COVID-19 or with COVID-19. You sit here 2 years into the pandemic, still unable to tell me how many disabled people, not the 10% of us who are on the NDIS, of the 4 million of us in this country, according to the ABS data, how many of us have died?
I've supplied the data that I have, Senator.
Okay. Senator Steele, John, we'll have to come back to that.
Thank you.
Senator Patrick, you've got 10 minutes. I'm going to start just
Thank you
really
very
chopping
much.
people off. Yeah.
Yeah, thank you, Chair. Someone might be able to help me out with this, but back January, midway through January, our Premier expressed public concern about rat tests not being or perhaps being intercepted by other states, and made a reference to a letter he might write to the ACCC. Now, I know that sort of doesn't really touch the Department of Health, but I just wonder whether or not the department engaged in any way or examined this, noting I think the Prime Minister made some comments about it as well.
Senator, it was a bit hard to understand some of that. We were cutting out some of the words, but we've certainly referred some allegations to the ACCC for investigation, where people were claiming that rapid antigen tests had been diverted by the government or the department.
And does that relate to the claim by the South Australian Premier?
So I think that the South Australian Premier, I'm not sure of the details of that, but I think it was about antigen tests being taken by other state governments. So I don't think that will have been referred by us.
So,
okay.
Acting Deputy Secretary Study Evidence and Research note, the only referrals we've made are from actual companies that have made those allegations and Queensland Rail.
We've also worked closely, Senator, with the ACCC on a couple of issues. They're leading on the work on price gouging and companies charging unrealistic and unreasonable prices for tests. We're working on the issue of where companies and some pharmacists have been repackaging bulk tests and selling them individually in Ziploc plastic bags, which is not legal, and we've undertaken compliance action against quite a number of those companies that have been providing product in Ziploc plastic bags. I should add it is legal for state governments to do so if they provide instructions under a special permission, but your average supermarket can't decide, but they'll make more money if they divvy up the kit and sell it out in individual plastic bags without instructions.
Yeah, sure. That doesn't really go to the heart of my questioning. This is about whether or not New South Wales or Victoria were in some way intercepting and I accept it might not be something that the department...
Sorry, no, Senator, Minister Hunt has gone on the record and categorically denied that the Commonwealth has intercepted any of those
I think,
tests.
Senator Patrick, you're talking about the interstate governments competing. I don't think that's our...
correct.
That's not our real bailiwick or jurisdiction to intervene, unfortunately.
Sure, I just thought you might have known something about that, but thank you. Questions of PM&C, and they directed to you, Mr. Murphy, and this goes into how you deal with misinformation. Just give a bit of a description about what's happening inside Health Monitor for disinformation, and then how you might respond to disinformation when it comes from perhaps a member of the public, an MP or a senator or a doctor, how you might treat those situations.
I think Ms Balmano is online.
I can talk about disinformation and advertising.
Well, you can certainly...
I'll kick off because we have a statutory role, Senator, if inappropriate information is provided about a product. And so if a product is advertised and it claims to do things that it can't, we can take regulatory action, which ranges from a warning letter through to criminal or civil court action. If it's a public figure, we will write to them. They are treated no separately from anyone else. There are certain issues where if people are not promoting a product, if they're saying don't get vaccinated, ironically, it is not actually an offence under the Therapeutic Goods Act because they're not promoting a therapeutic product, they're saying don't take a group of therapeutic products. And so there have been a number of people of high public profile who have made statements opposing vaccination, but that's not a contravention of our Act or indeed in working with other regulators, any of their legislation. We also have, again relating to products, a education and communications function which operates everything from social media through to paid media, advising people, for example, on such things as, well, if someone don't buy a rapid antigen test off the internet or a COVID treatment off the internet, you don't know what review it's been through and whether it works and so forth. We've done media, for example, saying, don't buy, for example, as I just said, COVID tests in plastic bags. And so our media has stimulated reporting of convenience stores and some pharmacies doing the wrong thing through to the ACCC in that case.
And Ms Balmano?
Ms Balmano is online now
she's over
to address the general issue, Senator.
Okay.
Thank you, Senator. Rachel Balmano, First Assistant Secretary of the People, Communication and Parliamentary Division. So beyond the regulatory sort of functions that Professor Skerritt mentioned, we obviously have quite a concerted effort to ensure that the community has access to the best available information about COVID treatments, about COVID vaccination. Part of that is certainly keeping monitoring for misinformation and countering that information, but also taking action such as blocking certain commentators from our own channels or recommending other agencies, government agencies do that, and reporting various accounts to the social media platforms who have worked with us very closely over the last few years to make sure that that they're quite responsive to reports of information to the against the standards that they each have set out for information on their platform. So we're very active in that, and we liaise with other agencies to identify those sort of sources. The main topics of misinformation continue to be that vaccines are in some way harmful or that they don't work, are probably the headlines. There is still also a reasonable thread of suggestion that COVID-19 does not exist or is not a severe illness, are probably the main topics.
Okay, so how do you handle that in circumstances? I think if a member of the public is doing it, you might shut down the platform by which they are communicating. If it's an MP or if it's a doctor?
Regardless of who it is, if we're concerned that they're promoting information that we know not to be correct through our channels, we will shut that down. We have a protocol about, and it's published on each of our channels, about our expected standards, and it includes statements about misinformation. It explains what we'll do. So we will contact them, we'll remove the specific comments initially and contact them and explain. But if there's repeated cases, we'll actually block that person from our channels. And similarly, we will report them to the platform if we're concerned about information that they're publishing through their own sort of accounts, not through ours.
Okay, just maybe finally, as a question, and back to Chief Medical Officer, can you just give us some statistics on the people that are being admitted to hospital and the those that are fully vaccinated, and I guess we're talking about since the population became vaccinated. Can you just give a brief little outline of give people some feel for whether or not the vaccine, the statistics show the vaccine has been helpful?
Thanks, Senator. So I'm not sure that I can give you some information on that. So there's a couple of things. One is we know the change in what's happened over the last few years, and I'll refer to deaths again because there's been a lot of discussion about deaths so far today. So if we take that as the most severe, obviously, outcome of this disease, the case fatality rate has decreased enormously in the last 2 years. Most of that is due to the vaccination effect, in my view. So at a population level, there's definitely been a change. Deaths early on were 3.2%, now it's 0.1%. Partly that's due to the virus changing itself, but most of the decreased severity that we're seeing from Omicron is almost certainly due to the protection that is given by 2 and even better by 3 vaccines. So that's one partial answer to your question. In terms of what we're seeing, fully vaccinated versus a lack of full vaccination, unfortunately that's another part of the data coming from the States that is actually delayed. So I do not have full information on that at the moment. What we have noted, at least, so this is in relation to ICU and hospitalisation and indeed cases. In terms of cases in previous waves, definitely 2 doses of the vaccine protected against people becoming infected. And so the majority of people that were infected were because of a lack of full vaccination, and that became even more the case with hospitalisation and ICU admission. With Omicron, that was not as effective. We noted that at least for the 2 vaccines, and that's why the booster or 3rd dose is so important in relation to that. But again, I don't have complete information on all of hospitalisations, ICU, and we've talked about deaths before in terms of.
But I think some of the states and territories have released information on ICU ventilation admission, and I think there's a high proportion of unvaccinated people in those ICU populations. But it is, as Professor Kelly said, the states aren't giving us all this information, but some of them have released pretty impressive information. I don't know whether you
Okay.
Yep.
I'm going to have to chop it
So
off.
just
Senator
very,
Patrick.
very quickly, Chair, just very quickly, and I only answer on notice, the difficulty to the state doing something different, I wonder if you can on notice at least get consolidated information to the committee.
Yes, definitely, Senator. And look, the issue is keeping up with the large numbers. That's the honest issue, and I don't blame my colleagues in the States for struggling with some of these more detailed information. Sure. They are giving us very timely information on numbers of cases, age, and so forth. So we've got good information on that in both total cases and the more severe end of the spectrum, and that's important.
Thank you. Thanks, Senator Patrick. Senator Henderson and then Senator Rennick, they're sharing their time.
Well, thank you very much, Chair. Professor Kelly, I'm just wondering if we could step back a little and just understand the nature of the Omicron variant, how Australia is travelling compared to other countries, and the tools that we're using as a nation to combat this particular.
Thank you for your question, Senator. So in terms of what we know around the world is that there is a huge Omicron surge in almost every country now. In the very brief time we've been living with this particular variant, there has been large numbers of cases all around the world. Virtually every country, Omicron has either completely or virtually replaced previous versions. At the time, you'll recall, it was a Delta virus. So we're facing very similar challenges to other countries, and I think that there's many tools we have now that we didn't have early on in the pandemic. So I think there's two elements that we've learned from Omicron. Firstly, the 2 doses of the vaccine is not as protective against infection and therefore transmission, but it remains partially effective against severe disease, and 3 doses are better. And that's a very important change in the tool we have. We've learned a lot in terms of that severe end of the spectrum about how to treat people in ICU and in hospital more effectively than we did early on in the pandemic, and that's information we've gathered both locally and from international interaction. Others have mentioned our regular meetings with Israel, for example, but I've also have regular meetings with many other chief medical officers to share experiences there. The other thing that we haven't mentioned so much today, but is the expansion of treatment options for COVID. Of course, none of those were available early in the beginning of the pandemic, and even last year there was only limited numbers. We've been rolling out 2 intravenous therapies to the states and territories, and they've been used substantially in states and territories from the National Medical Stockpile, remdesivir and sotrovimab, one an antiviral, the other one a monoclonal antibody. In the coming weeks, we will be also adding to that, and my colleague Professor Skerritt may want to talk about some of the oral treatments. Very exciting change to what we can do here in this country, as is happening in other parts of the world. So the way we're dealing with severe end, the way we're dealing with the transmission issue is changing, and this is the transition we're in terms of living with the virus.
Professor, can I just ask in terms of us still living in a pandemic in this nation, are you able to sort of give us some guidance as to when perhaps we might be moving out of the pandemic?
So the unfortunate news, I think we're pretty certain now that there won't be a Freedom Day as such. We will not be leaving this pandemic for some time. Certainly the discussions I've had, as I've mentioned, with other chief medical officers in the UK, the US and Europe, Israel, many other countries, New Zealand, we're all fairly much of this opinion now. This is not the end is not yet in sight in terms of living with COVID. I think the way we live with COVID is changing, has changed already. I mentioned the change in the mortality rate from Omicron in relation to previous viruses, variants of the virus. We've talked already today about the changes in furloughing arrangements, test, trace and isolate, the use of rapid antigen tests as part of our testing regime, our changes in the way we work with people that have either been diagnosed or have been close contacts of disease and having shorter periods at home. We've changed the way we've looked at public health and social measures over the last few months. These are all changes in terms of living with the virus. In the future, we will have more waves. I think we will have another wave of Omicron in winter. We may also have a flu to cope with during winter. We've seen COVID waves in every winter in northern and southern hemisphere winters throughout the pandemic from the beginning of 2020, and I don't think it will be different in terms of having cases, but it will be very different because of the booster rollout, because of the availability of treatments and the clinical care that we have both in primary care and in our hospitals that have been developed in terms of our response and the outcomes.
Professor, my last question before I hand to Senator Rennick. Australia has performed better than almost any country in the world in terms of hospitalisation rates and the death rate. What do you put that down to? How do you summarise the great success Australia has had compared to most other nations across the world?
So I think there have been a range of decisions that have been made early on, and Dr. Murphy's here. He was in my chair when one of the key ones was about the closing of the borders early on, and very strong public health and social measures in the absence of the other things I've already mentioned. I think we had a lot of planning for pandemics, which we were able to adapt to this new virus very quickly. We've remained very nimble in our response and being able to take whatever new information there is, even if that's incomplete, and share that with our governments, both at the national level and state and territory level. I think the pre-existing mechanisms we had, such as the Australian Health Protection Committee and their technical committees, which we were able to build on and strengthen, and now meet over 500 times during that period, and to make decisions and to advise the National Cabinet has been a crucial point. I think the vaccine rollout has been a success. I know that's a contentious issue amongst some, but it has been an absolute success, and the booster program is part of that. The rolling out to younger people as well has been part of that, and our ability to work through that as a society is extraordinary. I think Australians themselves have been incredibly open to these so many changes and so many different experiences throughout, and they've been extraordinary in listening to the public health message and hearing from experts and understanding what needs to be done. And I think all of us together, and I've finally put a shout out to the health workers working on the front line, aged care workers and others that have done an extraordinary job in clinical care for those that have needed it at the time when they need it, in the place they need it throughout the pandemic, even against all odds.
Okay, thank you, Professor Kelly. Thank you, Senator Henderson. Senator Rennick, you have 3 minutes you've been given by your colleagues, so feel free. Are you there?
Yeah, can you hear me?
Yep.
Okay. My question is for ATAGI, and then what I want to talk about is their decision to approve the vaccine for children aged 5 to 11. And in their report, they noted that the trial for children was not powered to detect any rare, unanticipated adverse events or to assess rates of myocarditis and pericarditis following immunisation. And I take it that's based on the TGA's report around the Pfizer trial that noted safety follow-up is currently limited to a medium of 2.5 months.
Senator Rennick, Senator Rennick, I'm having trouble hearing you. I don't know, can you talk into the phone a bit
I am.
louder?
I've got the phone
Clearer.
on now. Is that better?
Okay, I think I had trouble hearing. I don't know if anyone else did, if you got better hearing over that side, but perhaps, can you just start where you were?
Okay, sure. So do you want me to repeat or do you want me to
I heard you want to go to ATAGI about approval of the 5 to 11 vaccine.
Yeah, that's right. And so I want to note in their review that they said the trial was not powered to detect any rare unanticipated adverse events. And I'm assuming that's based on the TGA report that noted that data was limited to 2.5 months past the second dose. The sample size was small. The duration of immune response and vaccine protection is not currently known in that age group. Vaccine efficient efficacy against asymptomatic infection and viral transmission are not known. The data in immunocompromised individuals is lacking. Efficacy against the currently circulating variant of concern is not known, and no data on co-administration of the vaccine with other vaccines were also known. Now, I'll also note that the Doherty modelling made no recommendation for vaccinations of 5 to 11-year-olds last year, and they did note, however, that expanding the vaccine program to 12 to 15-year-olds wasn't going to make a big difference on transmission levels. And one other point that since the trial, promethamine was added to the vaccine. Now, given that there was limited short-term, gain, why would you approve the vaccine for children when there were so many unknown risks?
So Professor Crawford is on the line.
Okay,
Maybe
Professor...
TGA first, then Professor Crawford, because who's also a paediatrician.
Yes, it'd be good for Nigel as a paediatrician.
I think it was asked of Atagi.
Happy for him to, although a lot of the approvals are actually TGA.
Well,
but
he's only got 3 minutes, and that was the entire question. So
Good.
the answer, Professor Crawford, and then we're moving on.
Good.
Thanks, Senator Nigel Crawford, Chair of Atagi. So this deliberation was important in terms of the 5 to 11 years of age because we know they are at risk of COVID, and we know also impact on school and other factors. It was important to consider them as part of the vaccination program. The initial trial data was the phase 3 trial and relatively small numbers in terms of some of those safety outcomes. That's unfortunately the nature of lots of clinical trials. They're not often big enough to pick up some of these rare side effects, but we did know the background of myocarditis is much less common in those that are 5 to 11 years of age compared, for example, older adolescents and young adults do see more myocarditis. And also the provision of our advice that we knew the US was running with their program very quickly. So the United States have now given over 6 million double dose, and I think 9 million one doses in that 5 to 11 age group. And they've also reported and published on their safety data and shown a low level of myocarditis rates in that age group, and certainly we're happy with that safety profile and continuing with the program as per the Atagi advice to government. So there are lots of unknowns as we provide our advice. We take them into account and make sure they're clearly explicit in that advice, and as the answers come and the question arises or emerges from that international data sharing, we also update the program, but we're very happy with the safety of the Pfizer vaccine in the 5 to 11 year age group. Thanks.
Thank you, Professor Crawford. While you're there, can I just ask a question to you on another matter? But I understand whether a 3-dose, the original 2 vaccinations plus the booster is going to be defined, or the definition is for fully vaccinated is going to require 3 shots. That question is currently with you or with Atagi, is that correct?
That's correct. Atagi is currently deliberating.
Yeah. Can you give us one indication of when those deliberations might be complete and what you're considering as part of that?
So Atagi is deliberating, and we're currently meeting weekly still as a full committee. So that is being deliberated through the committee, and we expect that advice to come to government in the coming weeks. So in the next couple of weeks, we'll have that advice. I think the key deliberation we like to flag, Senator, is that we think the best terminology is actually up to date with vaccination status rather than fully vaccinated. And that's a term that we've used in the childhood program. So essentially, as you have your children get vaccinated, we say, are you up to date with your immunisations at a certain age or a point in time? And as those vaccines become due, you'll then get a report to say you're up to date with your vaccines. Please come forward with your 18 months to get those doses that are recommended. Because one of the issues, just to flag, is that if you're immunocompromised, you actually need 3 doses, not 2, to be fully protected with that primary course. So therefore, for that individual, they should have 3 doses of the primary course of vaccine, and then 3 months later get a 4th dose to be fully up to date with their immunisation, as opposed to the majority of the adult population, 18 plus, we're recommending a 2 doses primary schedule plus now that 3rd dose in a month's time. So there is some complexity at that individual level advice, which then also flows into the population determination and the Australian Immunisation Register. So all of those deliberations are coming through our TARGI with our broad expertise of that committee, and we will provide advice to government on what we define as up-to-date status of vaccination for COVID-19 and how that may change and vary over time.
Okay. Yeah, okay. So I don't think ATAGI had a fully vaccinated definition for the 2 doses. Did they? It was perhaps just something that grew out of the pandemic, some of the language of the pandemic and requirements for people to access certain venues and things like that.
We were asked to provide advice on fully vaccinated, particularly for international travels or people arriving. So we did provide some early advice around fully vaccinated, but again, the focus of our current deliberations are very much on what's the up-to-date requirement for the Australian population with the vaccines we have available, acknowledging that advice may need to be extended to think of different circumstances with lots of vaccines being used internationally, some of which are TGA provisionally approved. They're the ones we're using now in Australia, with Novavax most recently added to that list and hopefully coming into Australia soon, plus some that are TGA recognised and being used internationally, but the TGA would be able to talk to those components in more detail.
Yeah, okay, thank you. I'm going to go a bit around the shop, but can I ask the department, particularly the aged care part of the department, when it first realised that they would need rapid antigen tests to support the aged care sector? When was that?
Senator, the department commenced a program to supply rapid antigen tests for aged care surveillance in July 2021. So had been discussing with the sector for a while before that, but that's when the work actually started to collecting.
So that was the first, when you first, I'm talking like prior to running a program, when you first realised that you'd want to use rats in aged care. That was in July?
Well,
so the department hadn't done any work before then. I understood there was a CDNA document that had a testing regime or, document that existed from February that mentioned rats.
The testing framework for COVID-19 in Australia did say, I think the version published in February, said that we could consider potential use of rapid antigen detection devices for public health investigation or screening in specific epidemiological contexts. And one of those was high-risk facilities like residential aged care.
So is your evidence that the earliest work was done in February in putting that document together?
So that was work that would have been supported through the department's support of AHPPC. It was put together through the Communicable Diseases Network and the Public Health Laboratories Network.
Okay. And then specifically in aged care, your evidence is that it was in July that you realised that there would be some need for rapid testing to protect aged care and protect people, workers and staff.
There were discussions, Senator, and then the opportunity to provide assistance to a trial in Sydney in an aged care facility, which was then expanded.
Okay, that was in July.
That was
it?
in July.
So any policy work in the department is starting in July. Is that right?
So that's when we commenced our approach to market. We had funding provided to purchase rapid antigen tests for the purposes of providing through a trial to residential aged care facilities.
Okay. What did the aged care area think that rapid testing would be most useful for? Why did you think it was going to be useful?
Well, principally that in a situation where where things were opened up, that it would provide a mechanism for screening for that facility. It obviously it works with the furloughing arrangements, which is what has been critical in the Omicron phase. But yeah, it was principally around screening and providing, I think, confidence to staff in facilities who may be reticent about coming to work. It provided them with the tool to have that confidence to come in. Mr McBride might have more detail around that.
So they were the principal things. So both staff were concerned that they would be infected and then take that infection home, and they were concerned that if they were infected, they'd bring an infection into the RACF facility, and the fact that they could be screened and get that rapid result alleviated some of those concerns. And as it turned out, the trial proved that in some circumstances it did prevent potentially infected workers from entering the RACF.
Did the department do any costings of the quantities that would be required,
Well,
either
that's
based on that trial or after that trial, to protect aged care?
So the trial happened in parallel with the breakout in New South Wales. So what initially started as a 10-facility trial expanded to a 70-facility trial, and then because the initial findings of the evaluation that we commissioned in parallel with that trial were positive, we then expanded it throughout the New South Wales outbreak. So it ended up being 712, I think, facilities across New South Wales and then Victoria that received rats during that outbreak, but the trial itself extended to 70 facilities, and that trial proved, as I indicated, quite positive results.
My question was around costings. Was there any costings done?
So we knew the cost of the rats themselves because we went to market as part of that process, and there was a cost for the evaluation itself and a cost for at this stage they were point of care tests, so a supervision arrangement and a sort of a support tool for those RACFs that did it was part of the costing process. But what the approach to market showed us was a general indication of what RACFs would cost if we then scaled it up, which we subsequently did.
Okay, so when did the department start briefing ministers about the need for rapid antigen tests in aged care? So was it before the trial, or post the trial?
Before the trial.
So before July?
So we needed to get authority and funding to actually put a trial together. Yes.
Okay. And what was the allocation approved for the trial? Considering the trial started at 70 and then grew to 792, presumably there was to and fro between officers about that, because your original contract presumably didn't allow for that more widespread.
Well, the approach to market for rats themselves was for 4.45 million rats, which is about 32 million, which more than covered the trials.
Sorry, I can't. Just
Sorry.
In the microphone.
The approach to market in late July to 7 suppliers was for 4.45 million rats, which at a cost of 32 million. So, I guess at what we're looking at now for screening purposes, that where we've landed is a sort of a 72-hour cadence of testing. Originally it was earlier than that, but through the trial we were able to determine that a daily test was not necessary. So, as all things, a trial showed the benefits but also showed what the more efficacious cadence would be. So we've adjusted what we thought would be the requirements for rat tests for screening purposes as part of that process.
Okay, and which minister's office do you brief on this? Does it go to Minister Colbeck, Minister Hunt, the Prime Minister, the Treasurer? Who was involved?
So we would brief Minister Hunt and Minister Colbeck.
Okay. Do you provide any information to the Prime Minister's office?
Obviously, if you need funding authority, it has to go beyond those ministers. So for funding authority, it would have to go beyond Minister.
But did you provide a briefing to the Prime Minister's office?
Not directly.
About rapid antigen tests and availability?
We've provided plenty of briefings to the Prime Minister recently. We've been meeting with him, the Chief Medical Officer, myself, General Fruin, on a weekly basis. We've also been briefing National Cabinet. So, yes, there's been lots of briefings.
But in relation to purchasing of rapid testing, I'm going back to July last year for funding approval. How does that get taken to Cabinet then for funding approval?
There's a decision of government.
Yeah, but you don't directly brief, or you didn't in that instance, have discussions with the Prime Minister's office or the Prime Minister or the Treasurer or the Treasurer's office?
But they would all be present at the ERC meeting when the decision was taken, so it would have...
Yeah, it wasn't my question though. I'm asking if you were briefed Prime Minister's office in relation to the purchase of rapid antigen tests in aged care?
We provided advice to government, which resulted in funding and authority to conduct that trial, which then scaled up into a full program.
It's not my question again, with respect, Ms Shakespeare. I'm trying to ask whether you provide information to the Prime Minister's office at any stage last year about the purchase of rapid antigen tests in aged care and the availability of it.
We'd have to take that on notice, I think, Senator, to see whether.
Okay.
I mean, we have been briefing the Prime Minister sort of almost weekly on, you know, at National Cabinet, at other meetings, on every aspect of the COVID outbreak.
Okay. What, in relation to the use, so separate to aged care, were you providing briefs around securing supplies of rapid antigen tests for the National Medical Stockpile at that point?
We have provided advice. I mean, these were secured through the National Medical Stockpile, and over time there have been expansions of the numbers of rapid antigen tests purchased for the National Medical Stockpile. We've had several approaches to market now. We've got commitments to over 78 million, I think, at this point, being purchased for the National Medical Stockpile.
But those large purchases started in the January purchase order?
No. So, you know, we had, as I said, several approaches to market. There was one in the week before Christmas. There was one in the week between Christmas and New Year.
Okay, well, I'll have to go back and check Oz tender, because it looked to me like there was the big purchase happened on the 10th of January.
So that might have been when the contracts were finalised, but the approach to market was in December.
There's two medications. This is probably, sorry to jump around a bit. This is probably for you, Professor Skerritt. Paxlovid and one beginning with MOL.
Molnupiravir.
Molnupiravir.
Yep.
So Mr Morrison announced Molnupiravir on the October the 5th and said 300,000 doses been secured. Paxlovid, Minister Hunt announced on October 17th 500,000 doses. Have they arrived?
Doses of both of those have arrived into the National Medical Stockpile.
And when did they arrive?
The exact dates, my colleague Ms Platona may have the exact dates of arrival. It's in the last few days.
So, Senator Adriana Platona, both products are in the country, but both companies operate under pandemic conditions. So that means that not the entire 500,000 or 300,000 arrives in one go.
Sure.
So
how much has arrived then? Can you give me that?
Senator, there are conditions in the contract about confidentiality agreements. You'll forgive me if I take it back to our lawyers to discuss how best to communicate that publicly, or whether we can inform you in camera what we can tell you.
There was a media release. I mean, both were announced by media conference that you'd purchased this much.
Correct.
I'm not asking for how much has been purchased or in terms of cost or anything like that, but I find it a bit of a stretch if you can't tell me how much has arrived.
So the 300,000 and the 500,000, it's secured, and that means there is a purchasing agreement for both companies to deliver the product throughout 2022. If you look at Pfizer's media release, for example, they say they are working with government to deliver within a few weeks and within Q1. So there are conditions in the contract that prevent me from telling you exactly what is the delivery schedule. But I
don't want the delivery schedule. I just want to know how much has arrived in the country. If your view is you need to take legal advice on that, fine. I find it a bit difficult, acknowledging that these were announced publicly, the allocations. But I'm not going to push it. Neither of them, have you finally approved? You're provisionally approved.
So, Senator, both medicines are provisionally approved.
So that means they can be used when they're...
Yes, provisional approval simply means that there's more data, for example, on long-term effects, how long they provide cure, data on efficacy and effectiveness with bigger populations. It's a common approach used for medicines for a serious and urgent affliction. It is valid for up to 6 years, 2 by 2 by 2 years. After year 6, they have to go to full approval or be withdrawn.
Okay. When they were announced, why were they announced in October but arrived here in February?
So the announcement coincided with the advance purchasing agreements, which enable government to secure the 300,000 and 500,000 for delivery throughout 2022. The delivery and arrival in the country is linked to the date of the TGA approval,
so
which is 18th of January.
Okay. So when the government announces that they've bought these life-saving antiviral treatments and makes a big public splash about it, and they don't say it's going to be another 4 months until they're out in the market, could you have approved them in October?
No, Senator, we only received the final data a couple of weeks, a little bit longer for molnupiravir, but it was only a few weeks in that case and only a couple of weeks in the case of Paxlovid before the approval. So as for the vaccines that I talked about earlier, we did them as a rolling review, so we got a little bit of data in September, a bit more in October, but we only got the final data on them in December even between Christmas and New Year, we actually got a lot of the data. I had staff working between Christmas and New Year getting that data, and that's why the approvals were then in early January.
But the public announcement of them...
Well, that was about procurement,
October.
because you will recall that it's a very competitive world out there, especially for efficacious medicines. And so this is a most unusual but necessary step. We're in procurement agreements subject to TGA approval. So they were subject to our approval. It was all off. Where these agreements are set some months even before the data is submitted to the regulator. And this is happening globally. Other countries have entered very similar agreements.
So I guess the situation you're in now, where we've had an announcement that these life-saving drugs have been purchased, we've had a big community transmission and a huge rise in infections and the most deaths that we've seen through the pandemic. Like, if those drugs were available, could less people have died?
Senator, they weren't available anywhere. Because for clinical trials, in August, September, when the announcements and the agreements for procurement were done, the clinical trials were still being completed.
So they're not being used anywhere, these
They're
drugs?
just starting to be rolled out, I think, in the US. For example, in Europe, molnupiravir is not yet approved in Europe. I think it was 2 days ago that Paxlovid. We were ahead of Europe in approving Paxlovid, and molnupiravir is still not yet approved in Europe. FDA only approved them, I think it might have been just before Christmas or just after. So we were very hot on the heels of FDA. We were one of the world's first regulators to approve those 2 medicines.
And so, in terms of getting it out now, like, what will happen?
So we had a discussion earlier this week with the Director Generals and some of the Chief Health Officers from states and territories about the best way to start deploying these medicines. We are looking to, because they're most effective when they're used within the first few days of someone testing positive to COVID, we'll be looking to pre-place volumes of the medicines out of the National Medical Stockpile with the states and territories and they'll be looking at making sure these get to the people that can most benefit from them through their COVID care pathways, where they're recording information about people who are positive with COVID at higher risk. There's a set of advice we've got from the Clinical Evidence Task Force about the groups of patients that will most benefit from these two medicines. We're also looking at putting a pre-deployment with residential aged care facilities because one of the key populations are older people for this medicine.
And do you have enough?
We are...
Like, I know we're not allowed to talk about how much you've got, but are you confident that you can distribute it and it will, you know, meet the need that's out there?
We've got a lot of these medicines purchased through the pre-purchasing agreements. We're also working with the companies to try and get them listed on the PBS as quickly as possible so that they can be supplied through that general community supply mechanism that everyone's very familiar with.
Okay.
In the meantime, Senator, we've not been in a treatment-free zone. We've put out a lot of doses of other medicines, as I mentioned. The great advantage of these ones is that they are oral and can be used more quickly in the community. But Sotrovimab and Remdesivir that I mentioned earlier have been substantially used and put out from the medical stockpile to the states, and has been making a difference for many months. Remdesivir for over a year.
I should also, sorry, I have mentioned that we're looking to pre-deploy to Indigenous communities through community-controlled health services.
Yeah. The Living with COVID Task Force, who heads that up?
So that sits within the primary care area of our department. It's currently headed up by Miss Rishnu and Mr Bedford.
Sorry?
Miss Rishnu and Mr Bedford.
Okay, I'll come back to that at estimates. There was a promise of about 200,000 pulse oximeters that were to go out to GPs. Did that happen? Did GPs get that?
Apologies, Senator. Tanya Rishnu, Deputy Secretary, Primary and Community Care. Sorry, could you repeat the question?
There was a commitment under I understand, from the Living with COVID Task Force that, or associated with its work, that 200,000 pulse oximeters would be procured to go into general practice, primarily to support people with COVID or experiencing COVID in the community. Did that happen?
So, Senator, we're in the process of procuring. We've taken supply of 20,000 pulse oximeters. And as at the 17th of January, over 16,408 have been deployed to GP practices.
So what's happened there, if you went out for contract, like when you all knew that the opening up plan was happening in August, my understanding you went out for a contract in November for 200,000. GPs are looking after people now. So is there a shortage of pulse oximeters?
So the states and territories are obviously using pulse oximeters as well.
Yep.
So we're in the process of procuring the 200,000, and like most of the procurement, there are delays with supply chains, but we're getting those supplies in.
And do you know when you'll have the 200,000 deployed?
I'll have to take that on notice, Senator.
Okay. And where of the 16,000 you've got, have they gone to particular areas of need?
So I'll need to take exact details of locations that they've been deployed to on notice, but they have been deployed to, the conditions of deployment of pulse oximeters was based on treating COVID positive patients with symptoms.
Yes,
so the GPs will be letting us know that they are treating those patients, so they will go there first.
Okay. I just wondered whether you'd specified they go to areas where you have larger outbreaks or into First Nations communities or somewhere like that you'd prioritise within.
They were prioritised on the basis of treating patients with symptoms that would...
That was the priority test, nothing
right.
else.
That's right.
Okay. And finally, Professor Kelly, you mentioned that you're expecting a difficult winter or another wave in winter. What can you tell us about what you know about that, and will the government be upfront about what they are expecting? I think most people went into Christmas thinking we were going to have a better December, January than we ended up having. What's winter looking like?
I think I talked about this earlier. I think Senator Henderson asked me the question, Senator, but I'm happy to repeat. I don't have a crystal ball, of course, for exactly what might happen. I do know that there has been substantial Omicron infection in the past couple of months, as we've all seen, and probably much more than what has been actually diagnosed by PCR and rapid antigen tests. So there's a lot of people that have had Omicron. There is also a lot of people that have not had Omicron, and I think there's emerging evidence that people above a certain age have generally withdrawn from society over this last month.
Over what
for
age?
Protection.
What are we talking?
Sort of over 50, over 60. So they, of course, are the ones that we're most worried about in terms of severe disease. So if they have not been exposed, they are at risk of being exposed in the next wave of Omicron. There will be another wave of Omicron. It's most likely in winter. As I said, every winter in the northern and southern hemispheres since the beginning of 2020 has had a substantial wave of COVID-19.
So can I just, jump in there? When you say winter, are we talking August to November, or are we talking May to, is it basically temperature linked when it's pretty chilly here in May? What's your definition of winter?
So every June since 2020, we've had a wave of COVID-19 here in Australia, and other southern hemisphere countries have been similarly affected. It has not reached a sort of seasonal approach yet, because we've also had waves in summer, and other southern hemisphere countries have had it around Christmas as well. In the northern hemisphere, there has been increases, usually starting in about November or December, so early winter, in each of the winters since the start of the pandemic. Will that actually happen this time? I can't say for certain, but I believe we should be, and we are indeed planning for that eventuality. The other thing that has not happened in the last two winters, extraordinarily, is a flu season. We haven't had a flu season. We had only really a handful of hundreds of cases last year, and most of the cases of flu we had in 2020 were non-seasonal, so during the summer and autumn. Disappeared completely. We did not have a winter surge of flu then. We didn't have a winter surge of flu last year. There is flu circulating in the northern hemisphere, not in still less than usual, but it is happening. So flu has not disappeared from the world. So with 2 years of no flu, it's likely we will have a flu season. How bad that will be is speculation, but we should and are preparing for all eventualities, and that includes in relation to pre-purchase of flu vaccination for the coming season. A key component of our preparation for winter will be flu vaccine, boosters or third doses of COVID vaccine, the procurement and distribution and very clear guidance, which is already out there in public, for the oral treatments for COVID, and indeed using that as a springboard to make sure that we have our antiviral treatments for flu also available early on in the illness if it occurs.
And aged care?
Aged care,
Are you worried about aged care in winter?
Aged care, absolutely front and centre. We know that's the flashpoint for both flu and for COVID. And so, of course, that would be part of our planning, as well as communications and the usual things we do for a flu season. But one of the advantages we have compared with last year is, and Nigel's still online, Professor Crawford might want to talk about the flu and COVID vaccines being used at the same time. So that's an advantage we have in our preparations as well.
I don't know if Professor Crawford wanted to add to that. I can't see his picture anymore.
Yeah, thanks, Senator, and thanks, Professor Kelly. Yes, initially the ATAGI advice was to separate COVID with other vaccines, but because of obviously the emerging evidence and really wanting to optimise protection, we have changed that to say they can be administered on the same day. We still have some flu vaccine available from last year now in February, and clearly there will be the 2022 flu vaccine coming. So I do agree it'd be important that we get the messaging out there in terms of optimising protection from flu as well as COVID as we move into winter of this year. Thanks.
And will there be an advertising program on that, I presume? Yeah.
My colleague may want to talk to that.
If you're trying to get the message out.
So we're working with peak bodies already. We have a supply for the 2022 season. We have contracts in place for flu vaccines. And Senator, you'll remember that the over 65 population gets those free under the National Immunisation Program. So we'll be working through normal channels of making sure that that people, facilities, GPs and all of the usual distribution points are well aware and using that communications campaign.
Okay, look, I will finish there. I know people have got loads of questions, and I'm sorry to Senator Steele-John, who I've cut off, but we are out of time. Can I thank everybody for their attendance today? If for any questions on notice, we would like answers by the 16th of February. I know that's probably asking a lot, considering I just got one that's 168 days late, but the committee appreciates your attendance and the work that you've put in, both to appearing here but also over the Christmas New Year period, and the committee stands adjourned. Thank you.